clinicians need to understand, take care of patients. Every patient is different. Don't do the same thing in every patient, because that would be a very bad thing. You have to see what the patient is doing to be able to modify it. The same way as if you're driving a car. You actually turn the wheel occasionally. You accelerate and you brake. Okay? And in the same road, you turn the wheel and accelerate brake differently every single time you drive down the road, because conditions change. The patients are the same. Okay? But you have to understand how the roads go. So this is the road. All right? I have, if we have the time, I have a second lecture, a partial part I'll show you, which is a master class I gave in Santiago, Chile last year, called Effective Physiology. When you treat, how do you make a person better? For example, I can give norepinephrine to a patient, and their cardiac output will go up and their blood pressure will go up. Or I can give norepinephrine to a patient, their blood pressure will go up, their cardiac output will go down. Okay? You wouldn't want to be that second patient. Okay? But how do you know which one it will be beforehand? Well, you can, okay? And this is the second case, which is to take the first stuff and go to the next level. So if we have time, I'll go give a second presentation, but it really depends on you and what you want, okay? This afternoon, I'm going to give actually a grand round on called Effective Hemodynamic Monitoring, and this represents the publication that a large group of us made just last year. The paper is out, highly cited, and it's a good thing, not what can you do, but what monitoring-based treatments improve human beings' outcomes for the patient themselves. No, I'll stand. Okay, thank you. Okay, so I'm going to now talk about the first lecture, and this is the master class. I assume that it goes on now. Okay. Where's the okay. It's first of all, it's an honor for me to be here. Being a professor, to be able to allow to share with you my ideas and stuff gives me great pleasure, and to know that you're interested in this makes me feel good too. These are my conflicts of interest, and my conflicts of interest are primarily that I am studying cardiovascular physiology for the last 40 years. And I also have several NIH grants, and if I don't publish, they take the money away. And so there's a strong conflict to constantly keep publishing. Okay. We're going to start simple and get more complex. But everything I'm saying is true. The reason that you have a circulation, the reason why we evolved from a single cell organism to multi-cell organisms to complex organisms, for which humans are one of those complex organisms, required that we have a circulation. We could not survive and have the organ systems function without a circulation. That's the essence of how the species of the world evolved. Okay, they needed only two things to evolve: a nervous system and a circulation. That allowed them to evolve. So let's discuss this. The primary role of the circulation in every animal that I know, including man and woman, is to provide adequate amounts of oxygen to meet the metabolic demands of the tissues. And for free, you also wash out the carbon dioxide because the flow is in that direction. But you're actually delivering oxygen to meet the metabolic demand. Because that is the role of the circulation, one can define shock as a clinical state in which the tissue perfusion is inadequate to meet the metabolic demands. Period. Very straightforward. So the rationale, the initial resuscitation of people with shock, is that shock is the immediate systemic result of inadequate oxygen delivery to the tissues. Sustained tissue hypoperfusion results in end organ failure and death. Okay? Period. It's been said that circulatory shock is that brief period that all people go from health to death. Everyone in this room, unless you die of a ventricular fibrillation or your head gets cut off, will go through a shock period of seconds to minutes to hours on your way to death. This is how we all die. Since that is, when you see a person in shock, they are dying. If you are trying to resuscitate them, understand it's a medical emergency. Okay? The physical findings of shock are very impressive. The body presses out the maximum amount of sympathetic response. There is tachycardia, hypertnia, and diaphoresis. If you see a patient breathing like this, not the coughing, that's called hypertnia. You should be very afraid of the patient dying. This is a sign of cardiovascular insufficiency. It is the reason why hypertnia and tachypnea are listed on the Q SOFA for sepsis. It has nothing to do with sepsis. It has to do with circulatory shock. Anyone in shock becomes hyperventilated as a reflex response to increased blood flow. Okay? These are the cardinal things. Associated with decreasing blood flow to the tissues is any organ that's not being perfused doesn't work. You have decreased urine output, lactates go up, you get altered mental status, ileus, peripheral cyanosis, decreased capillary refill time, and capillary refill time is something everyone in this room should know how to do and routinely measure on any patient because it's highly reproducible and it tells you exactly what the tissues are doing. It doesn't work very well if you're on a vasopressor drug. But other than that, the patients on no drugs, capillary refill time is a phenomenally good way of assessing when you're looking at a patient first, how sick they are. Hypotension occurs late. If you wait for hypotension, you've waited too long. So we see tachycardia first and hypotension occurs late. Well, hemodynamic monitoring, are they tools or toys? Now, I'm a big believer in the one who dies with the most toys wins. But I do not believe that putting a device onto a patient without having any benefit for them will help them at all and may hurt. So we need to give monitoring that's effective. So I will tell you a fact. No monitoring device, no matter how insightful its information, will improve patient outcomes unless coupled to a treatment, which itself improves patient outcomes. So the focus should never be, do I need an echo? Do I want to put a PA catheter in this person? Do I minimally invasive? It is, what information do I need to give therapies that I know will improve my patient's care? Period. So the debate should never have been ever, do PA catheters work? PA catheter, by the way, the pulmonary artery catheter, is one of the most amazing hemodynamic monitoring tools in the world that has ever been invented. It just isn't needed for most of the stuff that we do. But if you have a person with heart failure and pulmonary hypertension and you're giving them nitroprusside because they have combined pathophysiology, having a PA catheter in to keep the PA pressures down while monitoring cardiac output by giving fluids and looking at the mixed venous O2 set to maintain adequate oxygen perfusion, I know of no better monitor. It's just that you don't see that sort of patient very often. But if you have a patient who needs a tool to drive treatment, that tool should be used, okay? So this is the truth. Okay, what are the treatment priorities? The treatment priorities is, which is what I'm going to go over now in the next hour or two, are these: pressure, flow, function. This is the priority. The first thing you have to do with a patient who is hypotensive is get their blood pressure up. I'll explain why in a second. Once the blood pressure's up, then you want to maintain flow to the tissues. But how do you know that a given cardiac output is maintaining flow of the tissues? I assure you, you don't. You then have to look at organ function to assess how the organs are doing. And so there is a sequence of priorities. You have to get the pressure up, then you get to make sure the flow is adequate, and then you say, what do I have to do to maintain organ function? And there's a lot of things that can screw up organ function with a normal blood pressure and a cardiac output that appears to you to be adequate. Okay, like intra-abdominal hypertension, for example, causing no flow to the kidneys and the gut. So the fact is, this is the priority. So let's start by looking at pressure. The optimal perfusion pressure is that pressure from the arterial side into the organs that allows for the auto-regulation of blood flow to improve to sustain metabolic demand. Remember that we said that the circulation's job was to sustain blood flow adequate to meet metabolic demand. Well, the reason that you worry about hypotension is if it prevents the autoregulation. What determines blood flow to your heart, your gut, if you've had breakfast, your kidneys, if you've had fluids, is not you or your mean arterial pressure. It is your metabolic demand of the tissue, okay? So the goal of maintaining a mean arterial pressure is to allow the tissues to get the blood flow they want as they need it to match their metabolic demand. If the pressure that is in the central arterial circuit relative to the outflow pressure is less than the amount that's necessary for autoregulation to occur, we develop ischemic organ dysfunction. And the other name for that is shock. Okay? Hypotension is a medical emergency. It must be associated with impaired blood flow. You don't walk to the patient's bedside, you run. So now we're going into physiology. How do we get the organ blood flow to be adequate? Well, we have a high input pressure in your central arterial circuit, and we're going to call that arterial pressure. And we have a high input resistance in the small vessels that prevent blood flow into those organs unless the organs want the blood flow. So the blood is trapped in this large central compartment, and it only leaks out as organs decide they need to have flow. Okay? It all stays right there. The primary method by which blood flow increases to any given organ is the organ's resistance vessels dilate. And when they dilate because of their increased metabolic demand, there is a passive increase in blood flow to that tissue. And it doesn't matter if it's the brain, if you're thinking, you actually can double or triple your cerebral oxygen consumption. Okay, they do really neat PET scans and stuff in the brain, and you can really see the increasing blood flow in the brain as you're working. Okay, the thinking. So that is the cause. Within this context, cardiac output is only important to maintain pressure. That is why in the priority of treatments, it's pressure, flow, function. If you don't have the pressure, you can't have the flow to get autoregulation. Okay. So the rationale for the defense of the blood pressure, it allows for the autoregulation of blood flow. So a corollary of that is that systemic hypotension in and of itself, by any etiology, abolishes autoregulation. I don't need to invent septic shock to have loss of blood flow redistribution. All I have to have is hypotension, and the brain or the heart or the organs that need it dilate up. There's no perfusion pressure. It doesn't matter. I've lost autoregulation. Is that point clear? Okay. That's a really important point. Okay. So let's take a look at the arterial circuit. This is from a study by Milnor, the father of arterial peaks, in which he was measuring the slightly out of focus. Somebody can focus this. It's in focus here. That's out of focus. Well, I apologize. Okay. Well, on my computer, this is totally in focus. Okay, what you're seeing here, can you see this? Okay, what we have is, this is the start of the aorta down to the large arteries, capillaries, and the veins. And on the top, this is the arterial pressure profile. This is through the aorta, the large arteries. And as you can see, the arterial pressure has a very distinct profile that is unique wherever you're measuring it within the body. Something happens at this point about here, and the pressure falls very rapidly. And this, as you can see here, was already known and codified in 1982. So this is not new information, okay? There, based on this, I can say to you that there's almost no arterial resistance. Did Michael Pinsky just say that? Yes, there's almost no arterial resistance. If there was, you couldn't use a radial artery catheter to measure mean arterial pressure, because it would be lower than aortic pressure, and they are identical. If the pressure in the aorta and the pressure in the radial artery are the same, then there's no resistance between those. There's no resistance between those 2 points, because if there was a resistance, the pressure here would be lower. That's physics. Do you agree with that statement? Okay, it has to be true. What does that mean? It means that in the entire large artery system of the body, it is one great big capacitor. And what happens is the heart only gives a given stroke volume. And that stroke volume doesn't go whoosh through the entire circulation. It simply increases the load of that capacitor, and the whole capacitor swells up. And then during diastole, it goes back down again. But the actual flow, if you were to put a flow probe on a radial artery, is almost zero most of the time. It's only going up and down if you start moving your hand and have metabolic activity. Blood flow is proportional to metabolic needs. If you're not using your hand, you're not using oxygen, and the amount of blood flow for resting muscles is very, very low. Okay? You with me? However, if you are really vasoconstricted, do any of you do cardiac surgery post-op patients? No. Can you do post-op cardiac surgeons? Anybody here do post-op cardiac? Okay, if you did, when they come back whole from the operating room, the radial artery pressure is often lower than the femoral artery pressure, because in them, they're vasoconstricted. And yes, there's a difference, but that's because this part of the body is cold. As soon as it warms up, they're the same. Okay. The thing I want to also show you is that not only is mean arterial pressure constant, but the diastolic arterial pressure is as well. So Vanina wanted me to say, how am I going to assess arterial tone? And I told her in this lecture I would show her. Okay. What I've drawn on this picture is the top is the arterial pressure waveform, and the below one is the aortic flow pattern. Now, obviously, aortic flow is in liters per minute, and blood pressure is in millimeters of mercury. But if the determinant of the arterial pressure was only flow, the two should have the exact same profile. If I were to have flow through a steel tube with a fixed resistor, I would see that the flow profile and the pressure profile would be identical. Engineers use this all the time to estimate flow of oil through pipelines. Okay, but that's not what's happening here. There's your aortic pressure, And there's your flow. And what you have is an arterial pressure profile that cannot be explained by an increase in aortic flow, stroke volume. Okay? So let's go into what that means. Okay? This is not accounted by flow. By the way, you agree with what I just said, right? Okay, good. Well, the mean pressures are the same. Think about the arterial circuit as this great big capacitor, which is all your arteries, all the way down to your dorsalis pedis in your foot, and your radial and ulnar arteries, somewhat almost to the digital, but not quite. Okay, that's all one great big physiologic capacitor, one unified capacitor. And at the end, there are all these blood vessels, which I'm showing as a little one out, which is the resistance with a tight little resistance at the very end. Okay. And with the stroke volume, if you were ever to go into cardiac surgery and see the chest open, you see with every heartbeat, the aorta goes like this. You can see it, it dilates up. It's a capacitor, and it goes back down with systole. Okay. And it's just holding on to this pressure. How much blood is pumped out of the heart in one heartbeat? 70 ml, fine. How much is 70 ml? Is it 70 ml? No, this is much more. A lot more. Half of that would be 70 ml. So let me take you, Fernando, and I cut open your chest, open up your aorta, and pour 70 ml into your aorta. It wouldn't get as far as your innominate artery. Okay? All you're doing with every stroke volume is charging the capacitor, the arterial circuit. You're not letting blood flow everywhere. And if you've ever seen angiograms, you see that too. We talk about stroke distance. In the descending aorta, the stroke distance is about this, 12 centimeters. So the actual flow in the aorta is very low. Why? Because that's not its job. Its job is to maintain a high arterial pressure so that the body can auto-regulate its own blood flow. Okay, doesn't that make sense now? I mean, everything is internally consistent. There's no secret message at the end. Okay. So there's your stroke volume. Now, if you're to look at, remember I showed you those arterial pressure profiles and they look kind of different as you went out. The systolic pressure started to rise as you went out to the periphery. Remember that? Yeah. How does that work? How can I possibly have a higher systolic pressure the further away I'm from the heart? I mean, that doesn't make sense. Well, it has to do with hydrodynamics. If you've been to beaches with the sand that goes out maybe 30 meters, and it can be about 30 meters and you're still up to your chest only in water, and the waves come in, do they crash on the beach? No, they come in slowly. Come out. But if you have waves coming onto rocks, they hit them and bounce back. In fact, the reflected waves, when a person is killed by being thrown against the rocks from waves, they rarely get hit by the rock. They usually get the reflected wave killing them, and they never, ever get touched by the rock, okay? That's just hydrodynamics. So the same is true for the body. With blood flow, and I'm going to pretend that it's just one vessel here because it makes the picture look pretty. Okay, you with me? But of course, it's all vessels. So here's my arterial pressure waveform, and there's going to be a pulse wave velocity. It's not flow velocity, it's pulse wave velocity. It's the pressure. You know, pressure goes very fast. You understand that when you're in the ocean and you're floating around and waves come by, the wave goes up and down, and that's pressure. but the water doesn't move. You just go up and down the water. Water's not moving at all. It's just a pressure wave going by. So there's a pressure wave, but there's no flow, right? And until you get to the very end and the waves kind of surf on or something. Up until then, the waves come by, but there's no movement in the water. So a pressure wave and a flow wave can be totally dissociated from each other just fine. So what happens is the pressure waves go down, all looking the same, until they reach bifurcations in which the cross-sectional area of the vessels decreases. And this can be thought of as those rocky coasts where the waves are hitting them. And they reflect back. Those are the reflected waves. And they cause a bump. And since it happens right at the same time as the wave that's going there comes in with it, it makes for a big pulse. But it came after the wave hit the wall. So it's going to be coming back with a phase lag going the other direction. So it's still going to be there, but it's going to be so later and later. And the summation of those are going to make the arterial pressure broaden out. Okay? You with me? And in fact, once again, this has been known for a very long time. Here's an example of the total arterial waveform. Let's just stick on the left now. This is a normal waveform in the aorta, and you can see that the aortic flow is shown here by the dotted line, and the reflected flow is here in the solid. And that as you go into the periphery, the forward flow doesn't change. It's the same in the aorta, the ascending diaphragm, and in the femoral artery. The pressure wave and the flow are the same, but it's the reflected waves that come in and make them higher. And you see the reflected waves increasing if you have increased vasomotor tone. Okay? All right? So if you have a person that's really anxious, they develop systolic hypertension. Wow. How did that work? It's just the reflected waves coming back. There's no change in stroke volume. It's just systolic hypertension. You see systolic hypertension and everyone is scared. There's this concept known as the white coat phenomena when you're measuring blood pressure in a patient. And if they come in, they always have a higher systolic pressure. So you want to have them relaxed, take multiple minutes, repeat it again. And then you see the systolic pressures goes down. They don't have hypertension after all. Or maybe they do, but it's not as bad. It's because the increased sympathetic tone immediately increases those reflected waves. Okay? Hopefully I'm giving you a lot of clinical analogies that show that everything I'm saying makes sense because you've seen it already. Okay? Good. So let me show you some data from Milner's original work at Johns Hopkins in 1980s, early 80s, in which he took a very high fidelity arterial catheter in a human being and put it at the aorta and pulled it slowly back all the way to the end of a dorsalis pedis. And so what we have here, and then he superimposed all the pressure profiles based on the ECG R waves so that they were all at the same time relative to each other. So this is at 5, 10, 15, 20, all the way down to 50 centimeters from the aortic valve. Okay? Now I'm going to show you now some of those reflected waves. But there are about 1,000 on this picture, and I can't show you all of them. But as you can see on the very top one, you can see that there's this little hat thing here. This is the largest reflected wave. Then there's the dicrotic notch. So this is the peak systolic pressure. That's your pulse wave propagation. It takes a certain amount of time for pressure to go down the aorta, right? Just as it takes a certain amount of time for the waves to go in the ocean. That's your systolic pressure. And it bounces back, comes up, bounces back, and comes up. Okay, see that? The ringing is occurring with every beat. With every beat, it rings. Every beat. It's the normal effect of having an elastic capacitor that the stroke volume, okay? So we did an interesting study a few years back. We actually, I'm not going to show you all the data, but this is just a pretty picture. We measured in the aorta, femoral, and radial arteries the arterial pressure using high fidelity Millar catheters, which are really super high. You could actually use it as a microphone. They're really that sensitive, okay? And we get, as you can see in this pig model, this is a baseline. The systolic pressure in the aorta is much lower than it is in the radial and femoral arteries. Now, the femoral artery in the pig is a lot further away from the heart, and then the radial artery is in the pig because of the shape of a pig, okay? In you, your radial artery is further away than your femoral artery, because if you put your hand down here, if you did the math, it's a little bit about this much further. So there's a slight difference, but who cares? All I want to show you is that in the setting of a normal animal, you can see that the systolic pressures increase, but the diastolic pressures remain the same. Now I'm going to show you that exact same animals, exact same pressures from the exact same thing after we had induced endotoxic shock and fluid resuscitated them back to the same mean arterial pressure. Endotoxic shock is a peripheral vascular disease. It causes loss of arteriolar tone through the induction of inducible nitric oxide synthetase and other things like hyperpolarization of the vascular smooth muscle. But for whatever cause, you can clearly see that when you then develop endotoxic shock, the periphery no longer has this augmented pressure. We did this study, by the way, to explain to the people at Edwards Life Sciences why their arterial pressure estimate of cardiac output needed to be modified, because it would never work in septic shock with the algorithm that they developed, and they wouldn't believe me. So this Dr. Hatib, who's the first author, is a senior scientist at Edwards, so we did the study together. I knew it was true, but when I looked at the literature, there was never a paper showing it. So I said, let's just do the study. Okay. It was amazing, because you know things are true, and you say, well, but no one's ever published that it's true. So I don't like publishing things I already know the answer to, but we did in this case. And this is the basis for how both all the new minimally invasive cardiac output devices recalibrate their systems based on the waveforms, because you can see the waveform looks different. And if you think the problem is due to loss of vasomotor tone, you put in different constants. And that's how they try to get better, okay? That's just an example of how that would be used, okay? Well, now let's go to the other point. If you will, the elephant in the room is that though I have a high arterial pressure, it really doesn't seem to have anything to do with the venous pressures. You see that? So what happens at this point right here? Is this an artifact? Does it not exist? No, it's true. I'm put catheters in the veins as far in as you can possibly get it. The pressures are really low. 12 millimeters of mercury, 15 at most. Put it into an arteries, it's 85. Okay, what's happening? The true back pressure to flow, let's assume your mean arterial pressure is 100. Your back pressure to flow is actually something like 40 millimeters of mercury. And that's because that's where the vessels collapse down. And what this has been called, and this is a little bit hard to follow, so I'm going to take a little time on this. This is called a vascular waterfall. Sometimes people call them Starling resistors. They're the same thing. And what it means is that the resistance, the downstream pressure that determines the back pressure to flow is not way down at the heart, but is much further up in the system. Okay? And this is true for in pulmonary hypertension for the pulmonary circulation as well, but in the normal pulmonary circulation, it's not. So Arterial resistance is clearly not uniformly distributed. And I'm going to say one other thing. There is no such thing as systemic vascular resistance. You can calculate the mean arterial pressure minus the central venous pressure divided by cardiac output. You can calculate it, but that is not resistance. If this were resistance, then the pressure would fall in a linear fashion right down to here. Systemic vascular resistance assumes a constant flow and a constant fall in resistance as you go further away from the heart because it's using a DC electrical current analog. Do you see anything in the circulation that even remotely resembles that? No. The reason that systemic vascular resistance became popularized was because of us. There was a time when we were treating critically ill people in the 60s and early 70s, and all patients who had a low blood pressure and were in circulatory shock had a low cardiac output. But then we had patients who developed septic shock, and we resuscitated them, and they had a low blood pressure, but a high cardiac output. So how could we explain that you could have a high cardiac output, but a low blood pressure? Max Harry Wild said, I will just calculate systemic vascular resistance, and I'll say, if the systemic vascular resistance is low, that's septic shock. If it's high, it's all other forms of shock. I have no idea why they said it, because he could have said if the blood flow is high and the blood pressure is low, that's shock, the septic shock. It's distributed. I don't need to calculate systemic vascular resistance. But we are habits. We do what we do because of the way we've always done it. The problem is it has no basis in reality, and I'll show you an example in a couple of minutes of why I was woken up at 2 in the morning by doctors telling me my patient was going into septic shock. Well, because they were calculating systemic vascular resistance in a person who had perfectly normal autoregulation. Okay. So the reason that the blood pressure falls so rapidly is that, remember I said there's essentially no flow in the large arteries, but when you get to the really smaller arterioles, the flow starts to go. And as the flow starts to go, there's resistance. And it's first going to be laminar, and then it's going to be turbulent. And you're going to see a marked fall in pressure over a very short distance, about 2, maybe 3 millimeters in distance. All the pressure falls. And you start to get a very low pressure in the vasculature because it's got resistance and flow is going up. So let's take a look at it. My mentor saw Herman years ago in 1983. He has passed. He was a brilliant physiologist. He was saying, what are the consequences? What are the consequences of having pressure go through vessels with tone? And he says, well, you know, you have a big vessel and it has the pressure inside it, arterial pressure, and it's pushing out. And the vessel has smooth muscle with tone, and you can consider it to be a circumferential arterial tone coming around, squeezing on the surface, right? You with me? Everyone with me so far? So now let's follow these exact same things as the vessels get smaller and the pressure falls, because now we have pressure fall because of resistance in the very small, the arterioles. So now, and there's the input pressure. So now I've got a very small vessel. The pressure has fallen because of the resistance. And now the pressure is only that. My tone hasn't changed. It's the same arrow that was on the big one. I haven't changed the arrow. Tone is the same. So I've got greater tone outside than in, and it causes the vessel to spontaneously collapse. As soon as it collapses, there's no flow. The pressure inside the vessel comes back up and it opens up. And so what it's doing is, I'm sure you've heard flow out of a flabby tube where it goes, right? That's the exact same thing. And it's all the resistance is broken right there, and on the other side there is none. Okay, You with me? That's how it happens. And it can be modeled as a Starling resistor. This is how Starling did it. Starling wanted to measure cardiac function in dogs. And he had them go through an artificial circuit when the systolic pressure went up and went to 0. He discovered if he did that, the animals died. Well, they died because they don't have any blood flow unless it's in diastole. So he figured he had to maintain the pressure within the circuit positive in diastole so that the animals wouldn't die, so he could study the left ventricle. So he said, I know what I'll do. I'll have the aorta connected to an output tube in which I'll put, he had a capacitor in which he had air in it, and he blew air into the capacitor. And he had a collapsible tube. And because this was up, this was the driving pressure for flow, and the pressure in the aorta could never fall below that because this collapsible tube would collapse. Okay? So there's your input pressure. Let's call it 100 millimeters of mercury. Well, if that's your critical closing pressure, and let's say it's 40, your true driving pressure is 60 millimeters of mercury, not 100. Is that clear? Good. There's your driving pressure. And the body, if it stiffens the capacitor to the same blood, makes it smaller so the pressure rises. If you vasodilate, it goes down. The pressure falls with no change in blood volume. How do you do that? Not magic. It just changes in capacitance. What does that? Sepsis, norepinephrine, nitroprusside. Those are the drugs you give your patients that have vasoactive properties. Okay? You ever wondered why this happens? And we'll go into real disease in my ran routes. Okay. So the upstream pressure can never be less than the pressure in the reservoir. Can't be. Because at that point in time, it stopped. The vessels collapse down and there's no flow. If you don't believe me, create one of these in your own lab now, prove it to yourself. We do it for first-year medical students all the time. All right? It's a vascular waterfall, and this is Victoria Falls. And the rate at which water falls over Victoria Falls is totally independent of how far it falls. It could fall 10 meters or a kilometer. It'll go over the edge at the same rate. Blood flow is independent of pressure. All the counts is the pressure difference up here and right there. But after that, all the downstream venous pressure, unless the pressure is higher than that point, will have no effect at all on flow. So an elevation of CVQ, for example, should not alter aortic flow itself. It will alter venous return, but that's the second part of my talk in this lecture. Okay? You with me? And this is Victoria Falls. And by the way, that's me. So when we think about where are these collapsible segments, we used to refer to them as a precapillary sphincter. Well, there's no such thing as a precapillary sphincter. If you look anatomically, there's not a hypertrophy of the smooth muscle in the arterioles as it goes. It's the same. What we have is the collapsible segment because the pressure has fallen enough that the normal tone allows it to contract down. Okay? So we decided to look at this in human beings. So we went into the operating room, opened up the chest of human beings, put a flow probe on the aorta, put our finger on the inferior vena cava, and watched how our arterial pressure and aortic flow decrease. This had never been done before. It took us 2 years to recruit 7 patients, and you cannot believe the IRB consent. So nobody got hurt, and obviously every one of these was a patient just about to go have cardiac surgery. Okay, but we finally had gold standard measurements of aortic flow instantaneously at the same time as we measured pressure, because all other estimates of flow are estimates. This was the gold standard. as you can see, as the arterial flow decreases, arterial pressure, pulse pressure decreases. But as you can also see, the diastolic pressure doesn't change very much. Saina, the diastolic pressure is not changing very much because the tone hasn't changed. Diastolic pressure is based on liver tone. I'll show you that soon, but that's, I'm giving you a pre-warning, don't get ready about that. But as you can see, the pulse pressure rapidly goes down, and accordingly, if you were to look at those exact data, stroke volume and arterial pulse pressure, you would see that they intercept a zero stroke volume at a pressure significantly higher than CVP. In this totally anesthetized, deeply anesthetized human being, the critical closing pressure, pressure is zero flow, and critical closing pressure, those are terms you'll hear in the literature a lot. I like critical closing pressure, but in the old days when I was a pure physiologist, we used to call it pressure at zero flow, PCF. So depending on how back you go in my papers, it'll say PCF or critical closing pressure. That is the back pressure. The driving pressure is not this point to zero CVP, it is this point to the critical closing pressure. So arteriolar resistance is significantly less than systemic vascular resistance. And therefore, the actual energy necessary to have vasoregulation is also significantly less than would be needed otherwise. It's a much more efficient circulation than you would think if you actually had to control a mean arterial pressure of 100 going to the various organs. Okay. That's the vascular waterfall. Well, with Yanita Moss, 2 years later, she asked, you did a bunch of studies in animals years ago to measure mean systemic pressure. Is that still true? I've always been amazed that something that you published 30 years ago, they question, is it still true? Okay. I think people quote books that were published about 2,000 years ago, and they don't question whether they're true or not, right? Chapter and verse. The answer is, if something's true, it's true. So I said yes. And so with Jos Janssen in the Netherlands, we went and looked at human beings, and we measured mean systemic pressure, which is the mean pressure in the circulation when there's no flow whatsoever, using a technique called stop flow, where we put the CPAP level at a fixed amount here. We measure instantaneous cardiac output, and we measure CVP. And we look at the cardiac output of the CVP, and we take the CPAP 2.5, 5, 7.5, and 10 centimeters of water for 15 seconds. Not a big change, right? But it's enough to cause the cardiac output to fall as right atrial pressure goes up. And we get a curve which gives you the mean circulatory filling pressure. Well, in these humans, we were measuring cardiac output and also mean arterial pressure. So we had the same cardiac output values, but we had our mean arterial pressure values, and there was our critical closing pressure. So folks, this is the vascular waterfall in a human being. Okay, it's real. This is the vascular waterfall in a human being. So when I say that the vascular waterfall is 35, and you right now, your vascular waterfall back pressure is about 40. And what happened? I think it's okay. Still okay? Sure. He's playing video. He's okay? You can prove this to yourself. Go into any intensive care unit where you're measuring radial artery pressure. And you say to the nurse, I'm going to do this. And then you take your hand and rapidly squeeze and stop all blood flow to the arm. Okay? Instantly. Just try it. Pressure will immediately fall in a logarithmic place down to about 40 millimeters of mercury. That's your critical closing pressure. Now, if you keep it occluded for 30 seconds, it'll fall down to mean systemic pressure because it'll eventually bleed out into that level. So you can do from the same vascular occlusion technique, determine your critical closing pressure and your mean systemic pressure. Jan Bakker, who lives in 3 different places at once, the Netherlands, United States, and Santiago, Chile. He has apartments in all 3 spots. My wife is sure he has 3 girlfriends. I told her, no, he doesn't. But he's a brilliant physiologist, clinician, and he measures this routinely in patients in which they're arguing about is there an effective circulating blood volume, what is vasomotor tone. If it's unclear, he just simply does this, and this solves the question. It answers you the information you need to say, is tone pretty normal? What is my effective circulating blood volume? Okay. So, let me tell you a story. Let us assume that that picture I showed you of a human being, I'm now going to show that same picture, but I'm just going to draw a line. Remember I showed you the human with pressure flow relationship, right? Remember that? Well, this is the same one. Only I made the pressure pretty. This is a change in pressure, change in flow. That is resistance. Okay? But the 0 point is here. So let me tell you a story. I was woken up at, I want to say 2 in the morning. I can't remember because I was asleep. And it was one of my residents. He said, Dr. Pinsky, remember you told us to give 2 liters of fluid to Mr. Jones because he was hypovolemic? Well, he's going into septic shock. Shoot, I said, or something like that. Tell me what happened. He said, well, the systemic vascular system was cut in half. I said, what happened to his blood pressure? Well, it stayed at 75, but his cardiac output doubled. I said, that's the normal response of a human being who's hypovolemic to getting fluids. And so I was woken up because they saw the normal response for calculated systemic vascular resistance. And I'm now going to show you why why vasomotor tone changes. Okay? I don't want to be woken up again for a normal physiologic response. Okay? Period. So if this is normal vasomotor tone, then we can say that if there was an increase in resistance, think about it, I need more pressure for the same increase in flow, right? That makes sense, doesn't it? Doesn't it? Good. And if I'm vasodilated, I need less pressure of the same flow. You with me? So we're going to go through these concepts with autoregulation and then with looking at different organ systems. Kidney, gut, liver. Kind of important organs. Okay? But we're going to start with the brain. If I have a fully dilated system, that's a very high slope, very low change in pressure, a whole lot of change in flow. If it's really vasoconstricted, it goes down to here. Okay? So, the references at the bottom of all these slides are the references of papers, and the majority of them are my own publications, but there are others. This was our summary paper wrote in the British Journal of Anesthesiology. This is the brain. If I were to look at perfusion pressure, which is arterial pressure measured at the jaw, minus intracranial pressure, that's what I'm defining as perfusion pressure of the brain. Okay? You with me? If I were to measure blood flow versus perfusion pressure, I would see that it would not be constant. So let's look at what would happen if I had a totally dilated circuit. I would have a very steep slope. So I need very little change in pressure for a whole lot of change in flow, right? That's vasodilation. You all agree? Yes? No? Yes? This isn't a surprise to you? And if it's very much constricted, it'd be steeper. That's vasoconstriction. So let's see what happens if we measure cerebral blood flow in a human being as we go from very high pressures to very low pressures. We would see that the curve is kind of interesting. At very high pressures, even though you're vasoconstricted, you get pressure increases and flow much higher than is necessary for metabolic demand. This is why malignant hypertension causes cerebral edema. Makes sense? That's cerebral edema. That's death. But why does it tend to be constant? Well, this is called autoregulation. And it's defined by the baroreceptors in the aortic arch of the carotid body that tend to maintain a constant arterial pressure, despite what the flow is, so that the body can autoregulate the blood flow through the vessels in a fixed manner. How does autoregulation work? Well, the body will vasodilate as the blood pressure falls, and vasoconstrict as the blood pressure rises to maintain a constant cerebral perfusion pressure. Okay. Right? You're all with me so far? Nod your head if you're with me. You with me in the back? Yes, you got it. But you don't have to worry about that. All you've got to worry about is this point right here. Okay? You want to be above the autoregulatory range because what did I say? Shock was below the autoregulatory range. Didn't I? That's where you want to be above. You want to be above that number. Okay? What is that number? That gets tough. I'll get into that now. But all you have to be is above this number, and the body will autoregulate its flow just fine. Thank you. Let me give you, I was discussing this, I think, with Arnaldo 2 nights ago. I said, I've never treated a patient for ARDS in my life. I've never treated a patient for acute kidney injury in my life. I have absolutely no idea how to treat. I have supported on the ventilator people with ARDS, and I've given dialysis and tried not to give renal toxin drugs like non-steroidals to patients with acute kidney injury, but all I do is try to hold them steady and allow the body to recover itself. Understand when you're treating a disease or supporting the patient, they're not the same thing. That's why iatrogenic excessive mechanical ventilation or too much diuretic or dialysis can kill the patient because you aren't treating those diseases. You're supporting the patient and allowing the body to recover itself if it can. I would love to treat these diseases. If you guys know any way to treat these diseases, please let me know. Okay? I haven't found one yet, but I want to. Okay? All right. What is hypotension? Hypotension is that pressure below which you're in trouble. The answer is there's no magic number. I'm sorry, don't get angry. This is the real world. In the study of over 8,000 patients from the Cleveland Clinic, they looked at the probability of dying, 0 being none. This is 1.1, which is 10% chance of dying compared to a healthy population. Okay? And this word is mortality. And you can see from 85 to 75 to 65 to 55, there's a linear increase in mortality. This word is AKI, standing for acute kidney injury, and you can see that it parallels it. Interestingly, myocardial infarction doesn't appear to have much of a response to blood pressure, probably because at hypotension you unload the left ventricle, decreasing its oxygen demands, which is probably a good thing. Okay. But what this means is that the higher the pressure, probably the better you are, the lower the pressure, the worse you are. But this is across a group of every single person in the ICU. Every single person in the ICU. And so one has to personalize it. What they also showed is it's not the blood pressure alone, but it's the blood pressure over time. A mean arterial pressure of 55 for 20 seconds won't hurt anyone. But a mean arterial pressure of 55 for an hour will kill you. Okay? So it's not just blood pressure, but it's the time-weighted average of blood pressure less than 65 in this example. And mortality and morbidity go up. What is that value? And there's acute kidney injury, it's the same. Well, we have a problem. We have hypertension. Patients that are hypertensive have increased vasomotor tone at rest. That's just the way they are. And so their normal autoregulatory range is shifted to the right. And what might have been a safe target, mean arterial pressure, for a healthy person, especially a young child, would be inadequate to maintain cerebral and renal perfusion in a person who had pre-existing hypertension. Okay? That is why we've said that you target mean arterial pressure of 65 or 15 millimeters of mercury less than their baseline if they were hypertensive. And what is the data to support that? Right here. These are the data in which they measured the least mean arterial pressure, or they measured it as a percentage of their baseline mean arterial pressure. And these numbers are we there for 1 minute, 3 minutes, 5 minutes, or 10 minutes? And as you can see, 65 is a magic cutoff point about which afterwards mortality goes up. But of course, it's for a long period of time, too. 10 minutes. 10 minutes is a long time. But if you've ever looked at anesthesia records or records of your own patients, you do emergent intubation, 50% of them remain hypotensive for 1 hour right now in your hospital. Across all hospitals, it's been published now in JAMA from a multi-center study of what was it, 29 countries. Everyone sees the same thing. So it's not just the United States or England or India, it's everywhere. Okay? Hypotension occurs commonly and we tolerate it inappropriately. It's a medical emergency. And this simply says if you're less than 15% below your mean arterial pressure where it should be, you're in trouble. So these are the data that tell you target 65 or 15% less than your baseline. Okay? So when we say that, it's not based on, well, I kind of think this. These are the data on 8,000 patients that show this is true. So let's now talk about the arterial pressure and how I can use this to plumb vascular tone. So the arterial pressure waveform is not a straight line. There is no one arterial pressure. If I ask you, what is the patient's arterial pressure? And you say 75, what do you mean? Okay. There is a systolic pressure, there is a diastolic pressure, and there is a mean, which is a third of the way between the diastolic and systolic, which we call the mean arterial pressure. And there is a pulse pressure, all of which are integral to our understanding of arterial tone and also ventricular function when I get to the heart. But I haven't talked about the heart yet. We're just talking about the most important thing, which is the vasculature. Okay? So the pulse pressure is primarily determined by three things. Stroke volume, and you saw that, right? But also the rate of ejection, because if you inject very quickly, the capacitor is not like a balloon, it's got elasticity. It takes a while to dilate up. So if you eject really fast, the pulse pressure rises with the same stroke volume. Okay? And also the viscosity of the blood. The diastolic pressure, which is what I want to talk about now, can be changed. We looked at in several ways. How do I assess arterial tone at the bedside? Well, I can measure an instantaneous change, arterial pressure to change in cardiac output. But I have to measure it really fast, and then I have to be able to measure it with an aortic flow probe or a transesophageal Doppler or a transthoracic echo, and it's a real pain. But you can do it if you really want to. And I have to cause the cardiac output to change, and the way we do it is a passive leg raise. When I look at the change in cardiac output, the change in mean arterial pressure over 10 to 15 seconds, because there can be no baroreceptor changes in 15 seconds. The smooth muscle response to changes takes about 25 seconds. The time constant for neuromyosin to contract to dilate, which is the microfilaments of smooth muscle, is too slow.
to instantaneously see that. So you can have an instantaneous flow if you wanted to, but it's hard to do that. I don't recommend that you look at that. Probably a much more reasonable way to look at it is to look at the diastolic arterial pressure. I will tell you right now that if your patient is in cardiogenic shock and you had an arterial catheter in him, you'd see that the arterial pressure would go up and it would go straight to a flat line and it would go up again. You've seen that, right? Absolutely flat, right? You've seen that. Have you not? Who has not seen that? Okay. The diastolic pressure is not low. The periphery is clamped down. Okay? If your diastolic pressure is low, you have vasodilation. Magic number in most human beings is 40. If your diastolic pressure is less than 40, then you're vasodilated. Remember I told you the critical closing pressure is 40. That's because that's the minimal it can be. All of this is consistent. I'll show you the data in support of what I'm going to say in the next 3 slides, but I'm telling you this is true. Okay? You can also look at arterial elastance. As long as the heart rate is constant, if you can measure stroke volume, you know systolic pressure, in systole is about 90% of systole because the heart ejects, and then when the aortic valve finally closes and the heart's smallest volume, it's about 90% of the systolic pressure. So you've got 0.9 times your systolic pressure divided by stroke volume is your arterial elastance. I'm going to go into arterial elastance in a very big way when I talk about left ventricular function and ventricular arterial coupling. Okay? But if you want to measure it, you can, but the heart rate has to be constant. Because if all I do is change the heart rate, I'll change the stroke volume. Okay? So as long as the heart rate is constant, this can be used. And the technique that I developed years ago, and we use now quite often, is to look at the dynamic arterial elastance, which is simply the pulse pressure variation and the stroke volume variation. And what this describes is the central arterial tone. And you and I, our normal dynamic elastance is 1.4 and 1. If it's less than 1, you're vasodilated. If it's greater than about 2, you're vasoconstricted. Okay? And it doesn't matter if you're on positive pressure breathing or spontaneous breathing, it's still correct. And you can do the same thing with the change in pressure to flow with passive leg raising. And all of this has been validated in multiple clinical trials, but this is not a lecture on clinical trials. The diastolic pressure is determined not only by cardiac output and arterial resistance, but blood viscosity and heart rate. So let me give you 2 patients. They both have the mean arterial pressure of 90 over 40. And this one's got a heart rate of 90. This one's got a heart rate of 120. So my question to you, which one of these patients is sicker? This one, number 1, or number 2? And then I'm going to ask you why. You understand the question? Yes. Which one is sicker? Okay, I will let you go off the hook because I think you're not sure. You want to answer? Maybe number 2 is going to be started. Okay, you're right. Number 2 is the right answer because they're tachycardic. Let us now do a Valsalva maneuver, something that causes the sinus rate to slow down so that all of a sudden now I have a sinus pause to give me the same RR interval as here. If I did that, my patient number 2 would probably have mean arterial pressure about 25. Okay? So, tachycardia masks hypotension. It's supposed to. It's how the body treats loss of vasomotor tone. It prevents blood pressure from falling low by not having as much time during diastole as possible, but it's really expensive for the heart. So, does a higher heart rate for given diastolic pressure mask vasopressin? Well, this was addressed by Mina Tortola and Ben Hernandez and Don Lee Poole there's a retrospective analysis of the Andromeda study looking at resuscitation of septic shock, and it's a really pretty study. What they wanted to know was that they looked at the heart rate divided by diastolic pressure. Jean-Louis Dubois loves indexes. I don't. I hate indexes. I like raw numbers. I love raw numbers because those you can see. But he looked at the diastolic shock index, and it was greater than 2. That meant that you were ill. What he looked at was the measurement of the diastolic shock index before giving vasopressors. These are septic shock patients who are hypotensive and needed vasopressors. Okay, that's the study. That's the Andromeda study. And then he looked at it after they got the vasopressor. And then he looked at their relative risk of death. And so this is the preliminary cohort that they modeled it on, and they had 5 groups. And this is the Andromeda study full data for all the patients, 450 or so. And so we can't see this well. I'm sorry, it's blurry. But the clear line here is the diastolic arterial pressure. The brown line is the heart rate. As you can see, as the heart rate goes, they put them in quintiles. Way to do it. Heart rate goes up, diastolic arterial pressure goes down. That will all be the same systolic shock index of 2. When that happens, the higher your heart rate, the lower your diastolic arterial pressure, the higher your diastolic shock index, and mortality went up. They then looked at all the patients, and they found the same thing. The higher your heart rate, the lower your diastolic pressure, the higher your shock index. So now let's have fun. They then said, let's just look at all diastolic shock indexes of 2. And let's look at a constant heart rate. But now the heart rate is not changing. But as you can see, the diastolic pressure is progressively decreasing. This is in the control, and this is the whole cohort. Heart rate's not changing. The diastolic pressure is decreasing. As the diastolic pressure decreases, mortality goes up with the same heart rate. Now watch. They said, okay, let's do the same thing for the same diastolic pressure. For the same diastolic pressure, as the heart rate goes up, mortality goes up. Okay? For the same diastolic. Tachycardia is never a good thing. Okay? It might be necessary to survive. I'm not disagreeing. But it represents evil. Usually cardiovascular insufficiency. It is bad. You should be, when your patient is sitting in bed, everything's fine, but they're tachycardic, they are not fine. Okay? People ignore mean arterial heart rate of 110. 2 days. They say, they're still 100, like throwing microemboli in their lungs, by the way. And we picked it up. I said, why ain't that? Why he's always at 110? No, you're not. Okay? These are the data that tells you that diastolic arterial pressure, less than 40, is associated with increased mortality, and tachycardia can mask it. Okay? These are the data. So when I say these things, these are the data that support this. So now let's switch gears. And let's now not talk about total blood flow, because I don't even care about blood flow. Let's talk about organ blood flow. The body could care less what cardiac output is. The kidney could care less what cardiac output is. The brain could care less what cardiac output is. All it cares about is its organ perfusion pressure, and it'll determine its own blood flow. Thank you very much. Okay? So let's look at the different organs. So in collaboration with one of my ex-fellows who now is running all of the Wisconsin healthcare system, which is a long time ago, 1989. Very famous now, but in an administrative way. He's doing very smart things. He's a great guy. We measured the blood flow in the hepatic artery, renal vein, and superior mesenteric artery of pigs And we put our finger on the inferior vena cava and rapidly had the flow fall over a period of 10 seconds. So we could look at the instantaneous pressure flow relationships of the organs with no change in autonomic tone, no auto-regulation allowed. Okay, you with me? And what do we find? We found that the kidney has very low resistance. Don't need much change in pressure, a whole lot of flow, right? That's low resistance. The liver has a high resistance. The gut's somewhere in the middle. And if you extrapolate them back down to zero, they have totally different critical closing pressure. The liver is a bunch of sinusoids. It really doesn't have a critical closing pressure, you know, the sinusoidal system, basically CBD or Catamine pressure. The kidney and gut are higher, and this is not kidney injury, it's just a baseline. I'm going to show you what happens with sepsis in a minute. Okay? So, does anyone here do liver transplants? I did the first 13 ever done in the United States a long, long time ago. Okay? Tom Stars was crazy. Okay. But we had to keep the mean arterial pressure higher than normal post-transplant because the resistance from the liver, the hepatic artery is very high. You do that. So 65 is not going to cut it if I want to maintain liver perfusion post-liver transplant. Okay? Has anyone done the left internal mammary artery to an internal coronary? Lima to LAD, it's called in the United States. Anyone here doing cardiac surgery post-op here? No. Okay. If you did, you'd know the exact same thing is true there. Because the systemic arteries that are coming in, the internal mammary artery has a high resistance. So I need a higher pressure to maintain coronary blood flow. This is just clinical correlates. Okay. So watch. If this is the instantaneous world that these organs look at, and we have a given pressure, and I'm going to draw the pressure here. Look at what happens if I get transient instantaneous hypotension. If I get hypotension, you see that I get massive decreases in renal blood flow. Slight decreases in gut blood flow, and almost no decrease in liver blood flow. You have never seen an ischemic liver in a normal human being due to hypotension. Because it doesn't exist. Okay, you can drop its pressure, the flow doesn't change much, and by the hepatic buffer response, portal flow goes up, but the hepatic artery flow goes down, so it doesn't matter. Liver response. The kidney is a setup for acute kidney injury. It's a setup for acute kidney injury. You understand? The kidney cannot tolerate hypotension. It immediately gets hypoperfused. This is why you saw the AKI step line. And with blood pressure, it didn't do well. That's why the fundamental nature of its pressure flow relationship demands that hypotension causes it to go down. In Australia, they believe that the mean arterial pressure should be 85 to 95 because they want to maintain renal blood flow. That's their opinion because of data such as these. And Ronaldo Bololo, who makes these statements, says, and I even worked in Dr. Pinsky's laboratory for 2 years, and that's why he's doing it. So he even posted, he was one of my students. He even posted it. All right. I don't agree. I think you should individualize it per patient. But in fact, that's the rationale. So, Iguazu, there are multiple waterfalls. There's not just one. Sorry. It's not my fault. Okay? This is the way the body gets. So you cannot target a single perfusion pressure and be guaranteed that all your organs are adequately perfused by just doing it. Do you understand what I just said? Good. So if we were to look for the heart and the brain, they auto-regulate to about here. So if I'm above 65, I'm fine. But if I have renal cardiovascular disease, hypertension or something, I need a higher pressure. You saw the kidney had a higher value. What if I have renal vascular disease? It's the same thing. There's no one magic point. There is no one magic point. So I'm gonna tell you is, clinically, You target a given basement, 65, and then look and see what the organ functions are. If it's not enough, you go up. If it's fine, you stay there or go down if you don't need it. Newborns can live just fine at 45 to 50 millimeters of mercury. It's amazing. You know, they're not human beings like we are. They're neonates. They're totally different. Their physiology becomes that of a human like us at about 6 months to a year of age. Then they start behaving like all other people, just smaller. But below that, they live on sympathetic tone and they have highly compliant vasculatures. And because they were in utero, they can become anaerobic just fine. Because that's the way they were for the last 9 months. Okay. Before I leave blood pressure, it would be wrong of me to say that perfusion pressure is mean arterial pressure. It is not. Mean arterial pressure is not organ perfusion pressure. If anybody does neurocritical care, you know that you have to subtract intracranial pressure or left atrial pressure, whichever is higher, to get your cerebral perfusion pressure, right? You knew this. Well, the heart cannot perfuse when it's contracting. No muscle can be perfused when it's contracting. It can only be perfused when it's relaxed. And so the organ perfusion pressure for the heart is diastolic arterial pressure minus CVP or intrathoracic pressure, whichever is higher. Okay? So if you give a drug like nitroprusside that causes significant decreases in diastolic pressure, you can cause the patient to have an ischemic myocardial infarction with normal coronaries because you're decreasing the diastolic pressure and decreasing coronary freezes, called type 2 coronary ischemia. Coronary ischemia without coronary artery disease. Okay? And it happens in about low percentages of coronary disease. With the troponins do go up, we see micro differences in flow and decreased mortality. About 50% of all patients in shock have some degree of troponin elevation associated with this. Okay? So, remember, I showed you the arterial pressure flow relationship. Well, years ago, we gave acute endotoxemia to animals and discovered, to our surprise, that there was no change in arterial resistance. But the critical closing pressure decreased. Remember, we said that on the arterial pressure that septic shock is a peripheral vascular disease, right? So the immediate effect of sepsis is to decrease your critical closing pressure. But after approximately 2 hours, the inducible nitric oxide synthetase kicks on, and your body makes nitric oxide or endogenous nitroprusside, nitroglycerin. They all just make nitric oxide. So it's your endogenous nitroprusside infusion. But you all know this already. Tell me if this is not a story you remember having in one of your patients. You get called because the patient is getting septic, Mr. Jones, dead floor, becoming hypotensive. You say, give him a liter of a balanced salt solution. There's great, blood pressure is up. So you go get a call. He calls you 2 hours later. Mr. Jones, hypotensive. Give him another liter of balanced salt solution. He says, the intern was here. He just gave 2 liters and nothing's happening. Okay, let's start norepinephrine. Who's done that? Who's heard that story? They respond to volume initially, and then they don't respond to volume and they ignore vasopressors. This patient is getting hypotensive. You give fluids, the flow goes up, their blood pressure goes up. This patient is hypotensive. You give them fluids, there's no change in pressure. They need to be given norepinephrine. Okay? So remember I showed you the data from the kidneys, mesenteric, hepatic artery. Now I'm going to show you the same animal after the induction of endotoxic shock. What ends up happening is all that wonderful individual specificity of the organ systems that allow them to accomplish their goals gets blunted and they become more homogeneous. That's bad for the patient, but it's good for you as a doctor. Because now you can target a given mean arterial pressure and you'll have the same relative increase in flow in all the organs. Okay? Sepsis causes all of them to change proportion of the mean arterial pressure. So I didn't show you the data, but Ronaldo Bellomo and Don Helm on my lab then took the septic animal and gave it norepinephrine to show that it increased renal blood flow and gut blood flow. When they gave the same animal norepinephrine before with sepsis, blood flow decreased because of the vasoconstriction. Okay. So to summarize the pressure part of this talk, perfusion pressure is primarily determined by organ perfusion above and below the autoregulatory range. Tachycardia, mass, hypotension. Any diastolic pressure less than 40 is probably associated with profound vasoplegia. Perfusion pressure isn't mean arterial pressure. You have to subtract the back pressure when looking at it. Autoregulation is altered in hypertension and sepsis. And what we recommend is that you target a mean arterial pressure. This is all the society say this. And I'm part of the society, so I'm an author on these papers too. The recommended 65 as a starting point, and then look at organ function flow. Okay. At this point, I'm going to take a break because the next thing we're going to talk about is flow. Okay. All I talked about so far is pressure. Flow is going to include venous return and left ventricular pump function. So before I start, does anyone want to take a break for about 5 minutes? Yeah, sounds like a good idea, but let's take a break for 5 minutes and come back, and I'll start the second part of this. And there's only two parts to this. The function can't be assessed per se. That takes too long, not for a lecture, it takes too long time-wise. Once you know the flow is adequate, then you look at function later. If we have time, I'll give another talk at the end of this in which I target how we look at flow. But I think it's too much for my talk. Okay, so we'll take a 5-minute break. Is that okay? Yeah. Thank you. Basic physiology. There's a lot there. I don't need to sound very much. But then the next question I know but I look at the diastolic pressure. Very simple. Now, I need to be very questioning whether or not we're getting present. Then you say, okay, thank you. I gotta get them to turn. This is not. It's not working. It's still not working. Let's see. Strong forward. I'll be going over that. Sí, sí, I'm gonna go over that in the next lecture. That is territorial class, it's not the municipality class, it is this language. Do you want talk to like yes, I cool down. Go lower to pitching. Well, what you don't know is that about 8 years ago, I had a brainstem stroke. And what I lost was really how to regulate temperature. So it means that I have to speak. I just want to. That's fine, it's fine. It's still, it's 25. It's 25. I don't want because that was the problem before. It was on, but it was hard. It's fundamental physiology, but it's directly what you see in your vision. Not good. Thank you. Hey. Well, you come from Pittsburgh, it's a very cold city. Right. 25. Yeah.
Yeah.
Sí. Hicimos el Waze, nos faltaban 40 kilómetros y nos salimos. So, when we talk about pressure, are you all feeling more comfortable now? And by the way, I didn't talk at all about how you measure pressure with a catheter, because there has to be zeroing and of the levels, and you have to make sure there's no bubbles. It's perfect. I'm gonna go down. Yeah, that's great. This is 20. 20 is good. So there's, every year in Brussels, on the Monday before the start of the Brussels International Symposium on Intensive Care in March, Jean-Louis Toul and I give a course on hemodynamic monitoring, making the right measurement at the right time in the right patient, okay? In which we go into how do you use hemodynamic monitoring, okay? That's a totally separate question than anything I'm talking about here, all right? Okay, now, are you ready? We'll start. We start. Are the people back from the Zoom on the rest of the world? I assume they're all back. Hopefully those that are listening through remotely are back on. I'm going to start the second part of this talk. Since the goal of the circulation is to meet the metabolic demands of the body, the relationship between oxygen consumption, which is VO2, and cardiac output is linear. The greater your metabolic demand, the greater your cardiac output. Because the primary determinant of increasing oxygen delivery to the tissues is blood flow. You can only do so much with increases in PO2 and only so much with increases in hemoglobin, but you can do a lot with increases in cardiac output. So why measure cardiac output? And the reference for why measure cardiac output is here. Knowing a specific cardiac output value at any given point in time, probably not important, unless of course it's zero. That's bad. Okay. Or you're using it to say, I want it to be at a fixed level for to prevent something else. Okay. There is no such thing as a normal cardiac output. It's a non-existent term. Cardiac output is either adequate or inadequate to meet the metabolic demands of the body and not the doctor's determinants of what it should be. Okay? So let's assume that this gentleman here's cardiac output is 5 liters now, and he's happy. So I'm going to put a flow probe on his aorta and a balloon in his right atrium that'll servo control to keep his cardiac output at 5 liters. And I'm going to ask him, Senor, could you please go up 2 flights of stairs and get coffee? Run now and come up and get it back. I really need a cup. He'll go up, he'll run up the flight of stairs. Assuming he makes it 2 flights, he'll become hypotensive, lightheaded, he'll fall down. We'll all come up and we'll measure him and his cardiac output will be normal. And we'll say, what's wrong? His cardiac output is 5 liters. It's not normal. Okay? It's grossly inadequate for the metabolic demand he was just on. Okay? If you have a person who's hypothermic after cardiac arrest and they're not waking up, so you keep them cool, right? Their metabolic demand falls. They need a cardiac output of 2 liters, maybe 3 at most. Okay. There is no right answer when you measure a cardiac output. What is it be? It is a point that you look at as a reference for giving fluids or time or drugs to say, is it increasing? And if it's increasing, is organ function getting better? Okay. You with me? So there's no target cardiac output that says they're normal or abnormal. That point clear? Doesn't that make sense, right? It does make sense, right? So why do you give fluids to your patient? Well, there's 2 reasons. The first is to do maintenance fluids. And actually, it's been argued that we shouldn't do that either, because with the exception of chronic patients in a very chronic unit where you're usually giving those integrally anyway, all you ever want to do is give the fluid boluses you need to maintain the effective circulating blood volume. Okay? And that's where we come in. Resuscitation to restore tissue blood flow. Okay? Now I'm going to be talking about a bunch of terms you may not be familiar with. The first is the total effective circulating blood volume, which is if I were to take you and totally bleed every bit of plasma and red cells out of you and I measure it in the beaker, that would be your total blood volume. But in that blood volume, we have an effective blood volume, which is how much of that blood volume is determining the driving pressure back for venous return to allow blood flow to occur. And for that, you have stressed and unstressed volume, and I'll describe those in a second, but they're a big deal. Stressed and unstressed volume is the most important thing determining cardiac output in normal people at all times. Okay, and I'll show you that in a minute. And of course, what we really care about is blood flow distribution, right? You want the blood flow to go to those organs that need it and not go to the organs that don't need it, right? That's the goal of the body. And then from a clinical perspective, we describe the ability to be volume responsive. What do we mean by volume responsive? Volume responsive means that if I give fluids and increase your preload, cardiac output goes out. Okay. Now, I presume that if I were to give a bolus of saline to every one of you, your cardiac output would go up transiently. I pray none of you are in shock. So just because you're volume responsive doesn't mean you need fluids. It just means that you've got normal cardiovascular reserve. But if you're in shock and you're volume responsive, please give fluids because they have inadequate blood flow. Okay. If I were to give you a liter of fluid right now, and let's assume your cardiac output right now is 5 liters, and I measure your cardiac output 2 minutes from now, what will it be? 5 liters. Why? Because the volume that I gave you has nothing to do with your cardiac output. It's due to your metabolic demands of the body. Now your urine output will go up, but your cardiac output won't. Okay. The only people in which the cardiac output will go up are those that are in shock. Okay, so when you keep giving fluids, the cardiac output doesn't go up. Stop. Okay. So fluids are really dangerous. This is an important sentence. There's 2 sentences. This is an important sentence. I'll explain these things in the next few slides, but this is important. Fluid resuscitation is done to increase mean systemic pressure because that's the only thing it can do. With the assumption that will it increase venous return by increasing the pressure gradient for venous return, thus increasing oxygen delivery in shock states where oxygen delivery is inadequate. That is the only reason to get fluids. Period. I'm not talking maintenance fluids, I'm talking resuscitation. Okay. Now, the very first time you see someone, you give them 250, 500 or something just to see what's happening while you're trying to get another handle. Might not be a bad idea. I'll tell you why in a second. But after that, you're flying blind if you don't start making measurements. Excessive fluid resuscitation causes hemodilution, decreases colloid osmotic pressure, increases capillary perfusion pressure, and edema occurs totally differently amongst every patient and everywhere in the body. Some people will develop intra-abdominal hypertension very quickly. Others won't have it at all. Some people get peripheral edema, some will get pulmonary edema. So the type of edema that you get from getting excessive fluids is different. Volume overload has a higher mortality rate than under resuscitation in shock. So giving fluids generically just because you feel better to give fluids kills more people than inadequate resuscitation. Okay. So I'm just going to show you one paper. Okay, I'll show you in a second. You're familiar with the concept of venous return. That's the blood flowing back to the heart from the body, right? So let's assume I have a given right atrial pressure. Oh, what's your right atrial pressure? You're right, yeah. Everyone's right atrial pressure is the same. If we add them all up, it's the same number, 0. That's what a normal right atrial pressure is. Why? Because right atrial pressure is the back pressure to venous return. And all it can do is impede blood flow back to the heart. So under normal conditions, we put the heart in a chest that's intrathoracic pressure is -2. So that even though it can go up slightly, the CVP, it doesn't go up by more than 2, so it stays at 0 at all times. And during spontaneous inspiration, the flow pressure actually goes even further down. So if I breathe in, I'm going to ask you this question again. I apologize. You are a doctor, right?
Yes.
Good. If I breathe in normally, flow pressure, CVP falls, right? What happens if I breathe in spontaneously and flow pressure, CVP rises? What's happened? Have you ever seen that? Breathing in and CVP goes up, not down. That's called Kussmaul sign. What does that mean?
The sign of Maui.
What?
The sign of Maui.
I don't know what it is. What's the word you're using? The name of the breathing. No, Kussmaul breathing. If you breathe in spontaneously and thorough CVP rises, what does that mean? Is that good or bad? Okay, why is it bad? You gotta know why. You gotta know why. It means right heart failure. Okay, it can be due to the pulmonary emboli. It can be due to overdistension of the lungs. It can be pulmonary hypertension. It can be myocardial anterior contusion from a cardiac, from chest injury, from a car, causing right ventricle is really the anterior ventricle. So that causes heart. But if you breathe in and CVP rises, that is very bad. The CVP should fall because it should always be below 0. Okay. This is the big deal. Okay. So if I were to now increase right atrial pressure, I would see in a steady state that blood flow would go down. And this was described by Arthur Guyton in 1957. And that's called the venous return curve. And when the right atrial pressure and the mean systemic pressure are the same, there's no pressure gradient, there's no blood flow. So the 0 flow intercept point, right atrial pressure is mean systemic pressure. Okay? The slope of the line is the inverse of resistance. It's not really resistance, it's conductance. Because unlike the arterial side, the flow on the venous side is laminar, and the way in which we get increases in resistance is by decreasing the number of parallel vascular channels. If I simply open up more parallel channels, the resistance goes down because it's conductance. It's like in the pulmonary circulation. The pulmonary circulation from artery to vein goes through a sheet blood flow through the capillaries. It's not individual capillaries, it's just a mass. And the same is true with the venous side. It's not arterial, it's venous resistance, it's venous conductance. And so if you cut off half the vessels, then you'll see a decrease in resistance. And also, the venous blood flow from your gut goes through another organ called the liver, increased liver, sorry, over here. The liver, and this causes, I know the liver, and this has an increased resistance too. So distributing blood flow not to the muscles, but to the gut actually increases resistance simply because anatomically you stick in another resistor. Okay? Has anyone here ever measured venous return? Raise your hand if you measured venous return. Has anyone here ever measured cardiac output? Raise your hand if you've measured cardiac output. Only one person's measured cardiac output. Raise your hand if you've measured cardiac output. Then you've all measured venous return. Because they are the same. They are the same. They have to be always the same. Exactly the same. Cardiac output equals venous return. And they're equal to the pressure gradient for venous return divided by the resistance for venous return. Okay? And you've all measured it. You actually have measured more oftenly If you use a PA catheter, you're measuring pulmonary blood flow. I assure you, you're measuring the venous return side. So remember that Starling measured right atrial pressure, and he increased in his artificial heart systems. The right atrial pressure, you saw the cardiac output went up into a plateau value. Okay. Well, if we look at the same numbers, I can put the venous return curve in there too. And as you can see, they intersect at one point, and that intersection point is called the equilibrium point. And it means that in you and your patient, there exists one and only one right atrial pressure and cardiac output that you can have. It's a function of ventricular pump function, blood volume, and blood volume distribution. Period. That's the equilibrium point on the venous return side. And it is venous return that determines cardiac output and not left ventricular function. Okay. A myocardial infarction usually is associated with increased cardiac output. Okay. Because of increased catecholamines. But a massive pulmonary embolus, you're dead. Immediately. This is venous return status. So this is the equilibrium point. So let's take a look at this for a second. Let's assume this is the normal venous return curve, and I now am hemorrhaging. And if I hemorrhage, I'll have less blood volume in the body, and so my mean systemic pressure will be less, right? Okay. So my curve will look like that. And if I volume load a person and don't allow them to pee, I will see the curve is higher. So look. For the same right atrial pressure, I can have 3 different cardiac outputs. For the same right atrial pressure, I can have 3 different cardiac outputs. Do you see that? So right atrial pressure doesn't determine cardiac output alone. It has to be relative to the blood volume and ventricular pump function. So if I have impaired ventricular pump function, everything else being equal, my CVP goes up. That's what we see in congestive heart failure, correct? And my stroke volume and cardiac output goes down. And what do you do in the unit? Well, for the patient, they fluid retain, or you give them fluids, and they get the CVP is even higher. But now, cardiac output's back to normal, and we call that congestive heart failure. But I assure you, it's congestive heart success. I assure you, this is the only way the body can survive on its own. Okay? If you don't believe me, take this person and diurese them down to this volume here, and they'll go into shock if that's all you do. Okay? So let's now look at what happens to the right atrial pressure. Let's assume I get this volume, my right atrial pressure is 0. And I rapidly give a bolus, and it goes up. That would be the increase in right atrial pressure. I'm going to give you a clinically relevant thing now, so be ready for this. But look at the person in heart failure. Not only is it higher to start with, but for the same bolus, it's a much greater increase in right atrial pressure. Okay? So let me rephrase this. Impaired ventricular function is associated with greater increases in filling pressure for the same amount of volume. Okay? It's a sign of badness. So, Maurizio Sassoni and the group at University College London, before he moved back to Italy, he's very happy in Italy by doing stuff. And they took patients post-op in the recovery room, and they measured mean systemic pressure using an algorithm that was developed by a guy named Parking. It's a great algorithm. And they gave fluids. One for 250, and another group they gave another 500. In all cases, when you gave fluid, mean systemic pressure rose, which meant you gave fluids. Okay? So then they said, okay, let's look at not just the mean systemic pressure that we measured, but the right atrial pressure, mean systemic pressure minus right atrial pressure, which we're going to call the driving pressure for venous return. You with me? Okay. So if we now look at this driving pressure, mean systemic pressure minus right atrial pressure, he then divided it into 2 groups of patients. Those whose cardiac output enough with fluids, which he called responders, And those whose cardiac output didn't go up with fluids. And as you can see, the driving pressure went up with fluids in the person who was the volume responder, but the driving pressure did not go up in the patients who were not volume responders. But in all of them, mean systemic pressure went up, which means that a rise in right atrial pressure identifies patients who are not volume responsive. Okay? Increasing CVP in a patient who you're giving fluids to should be a stopping rule. You should say to the nurses, give 500 of saline over the next 15 minutes. If the CVP rises by 2 millimeters of mercury, stop and follow. Okay? That should be the way you write the order. Because it shouldn't go up by 2 millimeters of mercury in a normal person who's volume responsive. And if it does, you're giving them too much volume, you need to slow down the volume or give none. Okay? And that's based on the concept of how venous return and right atrial pressure interact in terms of ventricular pump function. So we looked at this with Fabio Gattacino in patients with septic shock. And we measured their ventricular pump function, mean systemic pressure, fluids, as we gave fluids. If they were hypotensive, we gave norepinephrine. And if they were still unresponsive, we gave them dobutamine. Okay? Published a few years ago now. And we measured a whole bunch of stuff. I'm going to show you later on in this, their left ventricular pressure volume moves, because we had really great fun. We measured everything under the sun. So I want to show you now the relationship between the change in cardiac output and the change in driving pressure when you give fluids. Volume expansion. As you can see, as your change in driving pressure increases, cardiac output goes up. But what happens in those patients who remain hypotensive after giving fluids, and we started them on norepinephrine? Well, in some of them, their cardiac output went down. In some, it didn't change. Some it went up. But the change was totally predicted by the change in driving pressure. And this is the same axis. And what happened with dobutamine? With dobutamine, cardiac output went up because the driving pressure went up because CVP went down with the increased contractility. Okay? This is the, by the way, I could superimpose them all. It's the same line. Okay? Driving pressure determines cardiac output. Period. Okay? That's in human beings now. The other one was human beings too. So, why do I care? Well, because if I give too much fluids, I can be in trouble. So Bellamy described in the operating room a post-operative complication relationship that if you under-resuscitated people who are in shock and they come in for surgery, they have post-operative complications. And if you over-resuscitated them, they had volume overload, edema, gut leak, all sorts of bad things happen with their post-op complications. I don't work in the operating room. I work in the ICU when my patients come in with complications. But the sweet spot is much more reduced. One has to be extremely precise when giving fluids to critically ill people, because just a little bit too much, they push them into pulmonary edema and maybe the cause of death. And because just a little too little, may push them into acute kidney injury and be the cause of death. So you have to titrate your care very precisely. Okay? You do not do this over the phone. You have to be at the bedside. Maybe we'll be able someday to do this with artificial intelligence. I'm working on that right now. But at the moment, I need a good ICU doctor at the bedside looking at the patient. Whoever that ICU doctor is, she can be senior or junior, I don't care. But they have to be at the bedside physically looking at the response to the patient. Okay? Until they're stabilized. And this is the study, the first one that showed that cumulative fluid accumulation is one of the most common causes of mortality. And the number of studies since then have shown the exact same thing, is too numerous to count. Okay? Saline is dangerous. So, Remember, I was gonna talk about effective circulating blood volume and stressed and unstressed volume. Let's assume my mean systemic pressure is 10 or 12. And my total blood volume is this, okay? You with me? You understand what I've got? So I'm now gonna say, there's my blood volume and there's my mean systemic pressure. But if I were to change my blood volume, I would see that the curve looks like this. If I take away only a certain amount of blood, my mean systemic pressure falls to 0, but I still have all this blood here. Anybody here ever butcher an animal? Let's assume you take a pig and you slice their throat. You knock one at first, and you slice the throat and they let them lie there. Okay, of course they get hypotensive immediately because they go to the brain. Okay, blood gushes out. They stop bleeding. But most of the blood's still in the body. So what do butchers do? They then hang them by their heels and let gravity drain out all that extra blood, right? You're familiar with what I'm saying, right? This is not a surprise to you. Okay, that's because most of the blood in the body isn't determining pressure. It's in the unstressed volume. So we have an unstressed volume and a stress volume. And the reason is that the veins normally just change their shape, and there's no distinction of it. Think of it like a weather balloon, big, massive, flabby weather balloon that I put out here on the floor. And I asked you to please put in 1 liter of air. And what's the pressure? And initially 0. And I said, what's the pressure? Still 0. I said, I told you to put 1 liter of air in it. I did. Put another one in. Put another one in. It's still 0 until you get to a point that it finally gets a little bit of distinction. And then I get 1 or 2 millimeters of mercury. And then the next liter, I get 10 millimeters of mercury. Because I've reached the unstressed volume. Okay? And every vascular bed has its own unstressed volume. And so if you distribute blood from one area to another, you'll change the unstressed volume of the whole body. The gut has a massive unstressed volume. Muscles have a very small unstressed volume. So simply distributing blood away from the gut to the rest of the body increases your effective circulating blood volume. And that's why you decrease gut blood flow when you run. It's to essentially give yourself a 3 liter blood transfusion. Okay. And that's what your body does. Okay. So if I were to look at the total volume, that's called capacitance, but that's not really that important. What I really care about is the compliance. All you care about is if I give 250, 500 mLs of fluid or blood or whatever you want to give, albumin, I don't care. What's going to happen to mean systemic pressure? Remember, it's the driving pressure for venous return that determines cardiac output, right? So all I care about is the compliance. I don't care about the capacitance. I don't want to know. So I don't want to know hypervolemia. It's a meaningless term to me. It's real, but it's a meaningless term to me during resuscitation. What I care about is the compliance of the vasculature. So let me give you an example. This was a real example that Rothy showed in a paper. And I just schematic it here. Let's assume that this is my stress and unstressed volume. And I'm now going to give fluids, right? You with me? Here, I give fluids. Mean systemic pressure goes up. Watch, you see this? And this increases because of the fluid, physical fluids. The line came up here. So the fluid went in there, and that caused the mean systemic pressure to go up. So I've increased the driving pressure. But watch. If all I did instead was to vasoconstrict, to decrease the blood flow from those high capacitance areas into lower capacitance areas, so the unstressed volume went down, I could increase my mean systemic pressure much higher in a matter of 5 seconds. I'm going to ask you all to do something for a second. Please, everyone do this. Everyone stand up. Stand up, please. Thank you. Nobody fainted. Good. Please sit down. If you did not have a decrease in your unstressed volume associated with standing up, you would have fainted. People with dysautonomia faint when they stand up. You didn't, because as you stood up, you markedly immediately increased your unstressed volume and caused the increasing blood flow back to your brain and the rest of your body so that you were fine. And if you had diabetes or dysautonomia, you stood up, you would have fainted. And people are lying down in the examination room. Sometimes they're so relaxed, you tell them to sit up. They get lightheaded when you sit them up. And these are healthy people. It's for the same reason. If you put a person on a tilt bed and slowly moves it like this, they will faint because they don't get a change in the unstressed volume. And furthermore, if I vasodilate, if I vasodilate, I markedly increase my unstressed volume. And that's why people faint from vasovagal syncope. They vasodilate, all the periphery has more capacitance for blood than your entire unstressed volume. Your mean systemic pressure goes to 0 and you go flat. If you're in a dentist chair and faint, that's called the upright faint syndrome. And it's a cause of severe neurologic injury in people in dentist chairs because they faint, but they're still sitting up. The good thing is when you faint or your patient faints, they hit the floor and they become flat. And about 15 seconds later, the blood pressure starts to come back because everything's on the same level. Okay? So that explains why you didn't faint when you stood up. And that's why patients, no matter how strapping they are, when they have vasovagal syncope, they have no blood volume, even though they haven't lost a single drop of blood yet. They may have lost it from their head when they go down, but that's not the same thing. Is all this clear? Okay. The bottom line is the major primary determinant of an increase in venous return is an increase in unstressed volume, either due to you as a patient or you as a doctor giving a vasopressor. The primary method of increasing cardiac output in a human being is to increase unstressed volume. And it can be done in a matter of seconds, as you just demonstrated yourself when you all stood up. Okay? That is why there's absolutely no relationship between right atrial pressure, or CVP, and total blood volume, as was shown in this study by Jeffrey many, many years ago. So we looked at this in septic shock in an animal model, George Matushak and I got back in 1986. So we measured venous return curves as we gave 100 ml fluids up to 400 ml of fluid at baseline conditions, and then we used endotoxic shock and repeated it. And before we started both of these, we measured total circulating blood volume using an endocyanate read, so we calculated the total blood volume. And from that, we were able to measure the actual volume in and volume out of both the animal baseline and so what you can see here is that the actual total blood volume of the animal, as far as it was concerned, when it got into toxemia, was behaving as if it was bigger than it should have been. See that? It caused an increase in unstressed volume. And this is equal to exactly 20 mLs per kilogram. So in acute endotoxic shock, you behave as if you just bled 20 mLs per kilogram. That is why you give fluids to a patient in septic shock when they come in. They don't have to have any capillary leak or anything else. It's just that the vasoplegia is causing capillary leak. Now you'll notice that this number is not 30 mLs per kilogram. Okay, there's no logic at all of 30 mLs per kilogram, and the surviving sepsis guidelines finally took that recommendation away and said the evidence is very weak. You should give what you think is right, which is what we have been saying since the very beginning, and it's also why I was never asked to be on the surviving sepsis guidelines. Just for the record. How much fluid should you give to your patient in septic shock? I don't know. They eat some. Usually they were sick for a while, so they rarely do a lot of eating and drinking while they're sick at home before they come in. So they're going to be a bit dehydrated for sure. But the unstressed volume, that's going to be where they're going to need the benefit the most. Okay. And so giving a liter or two makes sense if they're hypotensive and have decreased capillary reflow time. Okay. So in sepsis, as I said, we have an increase in unstressed volume. Since each vascular bed has its own unstressed volume, if I decrease the number of beds I perfuse that I wasn't perfusing before because they weren't metabolically active, I must decrease the total amount of effective circulating blood volume because I have more unstressed volume. Okay. So let's now go and change gears. And now I'm talking about venous return. Let's say now, what will the left ventricle do when it gets the blood? Okay. All right. So what determines left ventricular stroke volume? Patterson and Starling told us preload, which is in systolic wall stress or loop stress, afterload, which is in systolic tension, and contractility. What Starling refused to talk about, though, was the ANRAP effect. ANRAP was a young Russian physicist who went to Cambridge and worked with Starling. And he looked at the data that Starling had and actually came to a different conclusion, and Starling didn't like him, so he left. He published in the German literature. Therefore, we never knew about it for a while. And now there's not one issue of circulation, the journal, that doesn't have an article on the ANRAP effect. Okay, just so you know, right? It's very important. But let's go through what it's all. All right, so you have to know. This was a simple study that was done many years ago, and it just demonstrates what I'm going to show you, which is this is 1959. They took a human heart, isolated heart, put it in a chamber. We were perfusing it with a solution called Krebs henselite solution, which should keep the heart alive and allows it to beat. Okay, you with me? And so this is the maximum volume. That stroke volume is too smaller volume, right? You get me? So here we go. There's the baseline end diastolic volume. There's the normal stroke volume. You with me? So all they did in this isolated, intact human heart with no circulating, with no innervation at all, totally heart in a box. They just turned up the pump. Bang! Immediately, the stroke volume went up. That's Starling's law of the heart. You with me? That's Starling's law of the heart. Instantaneous changes in preload cause an immediate increase in the force of contraction. No question about it. But look, with the pump still running with the same amount of stroke volume, after a couple of minutes, the end diastolic line actually falls to a lower level than it was before, but the stroke volume is maintained. That's the ANRAP effect. Okay, and the ANRAP effect occurs within about 3 minutes. And by the way, you all know this. You all are familiar with it. Every one of you is familiar with it, I'm sure. Do any of you bicycle or jog? Raise your hand if you do. Do none of you bicycle or jog? You do, but how about you? You don't jog? You do jog? You bicycle or jog? Yeah, good. Then raise your hand. So when you jog, you get on your clothes, you go outside, you start running, and you know you made a mistake. You're tired, but you've done this before. So you keep going, and after about a minute or so, you're looking at things, the juices are flowing, you're feeling great. The ANRAP effect just kicked in. Okay? You've seen it yourself. That's the reason why you can't look at steady state changes in preload to determine contractility, because by the time you look, you've already had an increase in contractility. This Starling effect, mechanically speaking, is due to an overlapping of the actin and myosin.
The ANRAP effect is due to phosphorylation of the calcium channels so that the same calcium can get in at a higher flux rate. So it only lasts for about 6 hours or so. So in an isolated heart and in human beings, for the mental stress, if you have exercise, we use for acute adaptation the ANRAP effect, not Starling's law of the heart. And chronically, we have hypertrophy and dilation. But ladies and gentlemen, this is where we live. We live between those two in the management of patients. We can't count on the ANRAP effect after a couple hours because it's meant for a transient effect. It's not meant for 3 days. We live in this period right here between these two. Okay? So I want to now look at how left ventricular function works. And one of the ways to look at it is to look at the various parts of the cardiac cycle from filling, contraction, to relaxation, which is called the left ventricular pressure volume. And so we have volume on the x-axis and pressure on the y-axis. And what we have to start with is the mitral valve opens. And when it does, because the pressure in the right atrium is higher than the left ventricle, the ventricle fills. There's atrial contraction, so it fills a little bit faster at the very end. And then because of electrical mechanical coupling, the heart contracts, the capillary muscles contract more first to keep the mitral valve patently closed, because if it doesn't, you get the mitral regurg. And then the heart squeezes in, shortens, and gets fatter and twists. All 4 things increase the intra-luminal pressure and then diastole, and you get isometric contraction, and the heart becomes not an ellipsoid, but a sphere. And at this point here in time, the pressure inside the left ventricle and the aorta become equal, and that miracle of nature, the aortic valve, passively opens and allows ejection to continue as the stroke volume then goes from end-diastole to end-systole. In an autopsy, it's hard to even find the aortic valve. You have to take a little probe and kind of push at the end of the aorta to see it. It's so thin. Yet we cannot create a valve that strong that can last for more than about 20 years with anything we use. And then most of us were over 20 years of age, and presumably most of us still have our own aortic valve. It's a miracle of nature. Okay. At this point in time, which is a big deal, we're in systole. The heart says basta, and it then does the energy-dependent part of contraction, which is relaxation. The energy-dependent part is active relaxation, and the pressure falls faster than it would if you allow it to drop. The pressure decreases faster than would happen if you just allowed it to open up to the atmosphere. It is active relaxation. Okay? Think of it like the heart is a crossbow. The energy is to cock it, but the contraction, you've already paid for it. That's why when a heart can no longer contract, it gets stiff, rigor mortis. Okay? That's why the first sign of ischemia is impaired diastolic relaxation, which you call regional wall motion abnormalities. Okay? This is all consistent, correct? So let's look at the Frank-Starling relationship using this relationship. Preload determines ventricular systolic performance, and it's determined itself by venous return. And preload is the primary determinant of cardiac output because preload is the primary determinant of cardiac. Venous return is the primary determinant of cardiac output. So we have this concept that left ventricular preload is in diastolic volume. And so if I were to look at a normal heart, I would see that over a significant amount of its filling, it actually has very little change in pressure for change in volume. But at some point, it starts to get much stiffer, and at the end, because of the fibers, cells, and the pericardium, it just can't get any bigger. Okay? And we define the compliance by the ratio of the change in pressure to change in volume. So remember, I told you that ischemia prevents relaxation. Remember I said that? So what happens with acute ischemia
we see an immediate increase in stiffness. The heart has zero reserve oxygen. If you blow up a balloon as an angioplasty in the coronary artery, you see on the very next beat, that segment of the myocardium does not contract. There is no oxygen reserve in the heart whatsoever. Zero. So as soon as I get ischemia, I immediately get a marked increase in stiffness. So for the same volume, I have a much higher pressure, and you go into flash cardiogenic pulmonary edema. Okay, for two reasons: one, the increased sympathetic tone, decreased unstressed volume, increasing venous return, and then I have a stiffer left ventricle, so the flow goes up. Okay, and that's why you go into pulmonary edema. So now let's do the opposite. Let's take this heart. I'm gonna put a Pinsky clamp on the aorta. So I won't allow any contraction. And I'll allow, the ejection. And I'll allow the heart to contract. The pressure will go up and come down. That's called isometric contraction. So they wait about a couple seconds, and the next ECG, the heart contracts again. It's got more volume in it, this was filling. And I see a larger systolic pressure, and you'd say that's Starling's law of the heart, right? Increasing preload, increasing force of contraction. You with me? Hey, what the heck? Let's do it again. Get a little larger, goes further. As the volume gets bigger, the force gets bigger, but what you're looking at is actually something even more beautiful, and that is the end-systolic pressure-volume relationship, which says that the minimal volume that the heart can have in circulate is a function of contractility and the air pressure it has to eject against. And it doesn't matter if I do it by an isometric contraction or from a given fixed end diastolic volume to a high, middle, or low stroke volume. This heart will live in this world, and it cannot exceed it. Is that point clear? Yes? So vasodilation increases stroke volume by causing the blood pressure to fall. Vasoconstriction decreases stroke volume as the arterial pressure rises. Yes, you got that? And it makes sense. So the slope of the end-systolic pressure volume relationship is independent of preload and afterload, and is a measure of contractility. Increasing slopes of the end-systolic pressure volume relationship increase contractility, and decreasing slopes decrease contractility. And here's the original paper from Suga and Sagala's work in 1973, showing exactly what I showed. This is a bunch of areas with IVC inclusion, with increasing epinephrine contractility, the slope of the line goes up. Okay? This is a big deal. We can use this. So let's assume that this is my normal left ventricle, and all I do is cause an impaired ventricular pump function. I will see a decrease in contractility. To maintain a stroke volume equal to what it is before, the body has to hold on to fluid. And remember, I call this not congestive heart failure, but congestive heart success. This is what the body does to maintain stroke volume. But you pay a price. Now I have peripheral edema and high venous pressures. But if there's no change in tone, I also see hypotension, which is why cardiogenic shock is defined by systolic blood pressure less than 90, not by cardiac output. It's designed by because the job of the left ventricle is to develop systolic pressure. This is job. Okay? Its job is to maintain the capacitor with pressure so that it can have blood flow distribution. That's why we define cardiogenic shock by systolic blood pressure. Furthermore, if we give an increase in contractility, heart filling goes down, so I go out of pulmonary edema and I increase my pressure. So there's my stroke volume from here to here. So if I have, and the maximal stroke volume would be here to whatever this point is, at the lowest pressure. So I can look at this now on a curve in which I'm looking at stroke volume, and I now increase the pressure. I have a decrease in stroke volume. I decrease the pressure, I have a decrease in stroke volume with the same contractility and the same preload. So I can plot a line of stroke volume to pressure for a given contractility, and it'll be linear. This is data we published a few years ago by the American Journal, which we simply increased left ventricular pressure, and that caused flow to remain constant, power to remain constant as flow progressively decreased. That's what I showed you before. The pressure goes up, the stroke volume goes down, right? That's what I showed you that picture. This is the human being. Pressure goes up, stroke volume goes down, but the power remains the same. The force, the heart hasn't changed its contractility. So this is a line that shows us that the arterial pressure falls, stroke volume goes up. This is like, and this is done. If I were to plot arterial pressure versus stroke volume, this is what it would look like. And this becomes important because I'm now going to show you ventricular arterial coupling. As you would see it in a patient, it explains why blood pressure and cardiac output do what they do with drugs and disease. Okay? The maximum stroke volume would be with the zero pressure. And this is for constant end diastolic volume and contractility. Well, you've already seen the arterial pressure relationship, right? We showed you that when I talked about the arterial pressure. Remember, arterial pressure and stroke volume, slope of the line, that's arterial elastance. And that means that in you and I and our patients, there exists one and only one arterial pressure and stroke volume that you can have on the arterial side. That's a function of preload, contractility, and arterial tone. Period. Just like on the left ventricle, right ventricle, there's only one right atrial pressure and cardiac output you can have. On the left ventricle, there's only one stroke volume and mean arterial pressure you can have, and that's the balance between preload and afterload. I mean, contractility and afterload. So this is what, in a diagram, your arterial elastance would look like this. And the paper we wrote a few years ago, it was an animal model in which we measured left ventricular pressure. So from 0 to where the aortic valve closes, the slope of that line is arterial elastance. The slope of this line that I'm not showing you is systolic elastance. This is just pressure and volume together. If you were a cathing cardiologist, this would look very boringly. This is what they do all the time. So there's my stroke volume. There's my arterial elastance. Remember I told you I increased arterial pressure? Well, how did I increase arterial pressure? I had to increase arterial elastance, right? I also increase arterial pressure. And I decrease arterial pressure. I have to decrease arterial elastance. So if arterial elastance goes up, stroke volume goes down. If arterial elastance goes down, stroke volume goes up. So opposite changes in pressure and flow, changes in resistance. Okay? Pressure goes up, stroke volume goes down. Pressure goes down, stroke volume goes up. Opposite changes in pressure and flow are changes in resistance. Is that point clear? So, if I simply increase my arterial elastance, my stroke volume goes down, my arterial pressure rises. If I decrease my arterial elastance, the stroke volume goes up, but the arterial pressure goes down. This is the opposite. This is just what I showed you before, but it's on this graph. Okay, you with me? This is going to be clinically relevant in a couple of seconds. All right. Opposite changes in stroke volume and arterial pressure, which tell you you've got a change in arterial basin over time. You can take that to the bank. If you're seeing that instantaneously made minimally invasive cardiac output assessments, you've got an art line in, you see opposite changes, that's changes in tone. The pressure determines whether the tone's gone up or down. Okay? I gave norepinephrine, nothing happened. What happened to arterial pressure and stroke volume? Nothing. You didn't give enough norepinephrine or they're not responsive. Okay. So what happens if I increase contractility? For the same stroke volume, I get an increase in pressure and stroke volume with increases in contractility, increase in pressure and increase in stroke volume. And if I impair ventricular function, I get a decrease in pressure and decrease in stroke volume. So changes in contractility alone cause a parallel increase or decrease in stroke volume and pressure. And this is simply showing that same thing from our paper in humans, where we gave dobutamine or propranolol and showed that when you give dobutamine, you get a decrease in power, and with propranolol, you get a decrease in power, and the flows change accordingly. So what I showed you in the pretty picture is also true in real life. So increases in contractility would be an increase in the slope, right? Increasing pressure and stroke volume. And decreasing contractility would be a decrease in pressure and stroke volume. Okay, so the parallel changes in pressure and stroke volume may represent increases in contractility. Okay, but this takes time. It can't happen from one heartbeat to the next. It has to be a change in contractility. So it may take several minutes of drugs. Well, what happens from one heartbeat to the next? Changes in preload. As you breathe in or out, preload can go up or down, right? So let's see what happens with preload. That can't happen in a single breath. What happens in a single breath? I can have a significant increase or decrease in stroke volume. That will look like that. And I will see if I'm plotting individual stroke volumes that they will be falling along the curve that looks like that. From the increase to the decrease in preload to the individual heat gain. Okay? And that's the basis of pulse pressure variation and stroke volume variation to determine volume responsiveness. This occurs very rapidly, and this is the reason for the dynamic parameters. It occurs within a single breath. So let me give you some clinical examples. I go from a given arterial pressure of 70, stroke volume, let's say, is 24, and now my arterial pressure is down below 70, it's now 60, then my stroke volume is less. Okay? So I've got a decrease in pressure and decrease in flow. What happened to my patient? Impaired contractility, right? This is parallel decrease. You might have given them propranolol for all I know, or esmolol. I don't know. Or they could have just had a heart attack. Your call. Or too much anesthesia if you're in the operating room, because anesthesia impairs contractility. Let's have the same decrease in arterial pressure, but the stroke volume goes up from where I was before. The stroke volume before was 20, now it's 25. But I have the same fall in blood pressure. So I now have a fall in blood pressure, but an increase in stroke volume. Okay? Same fall in blood pressure, but now stroke volume went up. What did I do? What did I do? I gave a vasodilator, right? This works when I'm not around. How is it possible that with the same mean arterial pressure, I get an increase in stroke volume? It is not possible to have the same mean arterial pressure and an increase in stroke volume by only changing contractility of the heart. I have to also vasodilate the arterial circuit or blood pressure will go up. What drug increases contractility and has a vasodilating effect? Thank you very much. Magic. Okay. Now, let's keep the stroke volume constant, but the arterial pressure goes up. I cannot just have an increase in tone because stroke volume will go down. I cannot have an increase in contractility alone because then stroke volume will go up. What allows stroke volume to be constant and arterial pressure rise? I have to have a combined increase in contractility and increase in vasomotor tone. You can answer. What drug increases vasomotor tone and contractility? B. Noradrenaline, norepinephrine. Magic. Okay. Finally, for the same stroke volume, if the blood pressure falls, it may be due to decreased steady state venous return. What drugs cause decrease in steady state venous return without an alternate contractility? That's what vasodilators do. Okay. So everything you see from the left ventricle can be understood by answering the question, what happened to the change? Blood pressure is still on. Exactly, you see your patients happen. Okay? And this works when I'm not in the room. This works. So this is an example of our patients in septic shock. And here is the left ventricular pressure line movement baseline in gray. And then we gave norepinephrine. This is only the patients who subsequently needed norepinephrine that I put back here. And you can see that when you gave them norepinephrine, the arterial elastance increased because you gave norepinephrine. It's going to increase vasomotor tone. And there was what looks to me to be a decrease in contractility. But the problem was in some of the patients, cardiac output went up, and some of the patients, cardiac output went down. So we looked selectively at the two different groups, those whose cardiac output increased, which we called the responders. They look like this. Yes, they had an increase in arterial elastance, but they had an increase in contractility because they were adrenergically responsive in their myocardium to the norepinephrine. What about the patients who didn't? They look like this. They had a fall in their systolic elastance because the afterload was too much for them. So, for example, if you cross-plant sending an pulmonary organ for the aortic aneurysm repair, or if somebody gets shot in the belly and the aorta, and they're an old person like me, their cardiac output goes down. But if they're a young person like you, they can handle the increase in pressure. Their cardiac output goes up because they get more venous return back from that area where you're no longer producing. So the response to norepinephrine and septic shock is a function of your cardiac reserve. And you can predict it ahead of time by their pulse pressure or stroke volume variation around positive pressure breathing, because that is a surrogate for volume responsiveness. And volume responsiveness is a measure of contractility. So is cardiac output responsive to fluid loading? Most of the time, almost done. I'm doing well. Yeah, almost done. We assume that venous return, left ventricular preload are the determinants of cardiac output, and we evoke Starling's law of the heart, and we assume that they are low end diastolic volume with volume responsive, and we attempt to measure with surrogates. Well, that's been looked at, and it doesn't work. If you look at CVP versus right ventricular end diastolic volume, there's a change in C versus change in CVP, which is change in right end diastolic. Or wedge pressure with left ventricular end diastolic volume with a change in patients in shock being fluid resuscitated, as Kumar did in Joe Cabrillo's lab, where instead of looking at end diastolic volume, looking at stroke volume, there's no relationship at all. If you learn nothing else, learn this. Preload is not preload responsiveness. I can have a small ventricle and not be volume responsive. I can have a large ventricle and be volume responsive. The most common form of heart failure today is diastolic dysfunction. It's heart failure with preserved ejection fraction. It's the most common form of heart failure. Give those people volume and they'll go into pulmonary edema. So do not use measures of preload. They all are inaccurate. What we can do though is we use Starling's law of the heart and dynamically change the preload with positive pressure breathing. And as you know, with positive pressure breathing, as you increase and decrease intrathoracic pressure, it'll alter venous return. And as I showed in 1984, with a positive pressure breath, increased CVP, positive right ventricular stroke volume to fall. And a few years later, Andre Deneau from us went into the operating room and measured left ventricular areas using automated order detection algorithms from transesophageal echo. And we showed that 2 or 3 beats later, there's a decrease in preload in the left ventricle with a decrease in pulse pressure. Okay, so this was all known in 1984. So can you please raise your hand if you weren't born yet in 1984? Raise your hand. Then I can comfortably tell you, we knew this before you were born. Okay, this has been known for a long time. This is the basis for looking at pulse pressure variation, stroke volume variation, and volume responsiveness. Let's assume that I've got a good heart or a not so good heart, and they're both underfilled. And during the positive pressure breathing, I'm going to see the end-diastolic volume oscillating values around here. I will see in both hearts an increase in stroke volume variation. As I fill them up, the not so good heart won't have any stroke volume variation. The good heart will. Eventually, all hearts become non-volume responsive. So in collaboration with Jose Marquez, we did the study I told you before, in which we measured not only arterial pressure in aortic flow, but we also measured descending aortic flow and cleft pulse oximetry. And what we found was, which is important, that over the physiologic range, the only change in arterial pulse pressure is due to a change in stroke volume. So from one heartbeat to the next, not over time, but from one heartbeat to the next, the only thing that determines a change in pulse pressure is a change in stroke volume. Okay, and I can measure pulse pressure in anyone. So in collaboration with Jean-Louis Dubois and Frederick McCarr, we published in 1999 the concept of pulse pressure and stroke volume variation. Well, you have your systolic and max and min, that's pulsus paradoxus, but it doesn't take into account changes that are occurring in the diastolic side. What you really care about is the decrease to increase in diastolic max and min, and that is your pulse pressure. And over the mean, that's your pulse pressure variation. We showed in septic shock patients that your baseline pulse pressure variation predictor subsequent increase in cardiac output in response to fluids. And it doesn't matter if you use pulse pressure or if the arterial cleft signal is just as good, or you can use the aortic VTI if you like echo, it's your call. Or you can use SVC collapse, as Antoine Blore does. It's all rock and roll. It's all the same thing. You're looking at dynamic changes in flow to predict volume responsiveness. You can, if a person's breathing spontaneously, you can't use these systems. So for that, we do what cardiologists have done for almost 200 years. That's a passive leg raise, which is equivalent of giving about 300 mLs of fluid into the body. And in collaboration with Baker Monet years ago now, we did a spontaneously breathing patient with atrial fibrillation. We did a passive leg raise, and we showed we could predict volume responsiveness. More importantly, if you were not volume responsive with a passive leg raise, we didn't have an increase in breakout with a passive leg raise. We didn't have an increase in volume responsiveness. And in our very first paper, we said that dynamic parameters will prevent you from giving fluid to a patient who's not volume responsive. Remember, volume overload kills people? And that's why this is important. One of the interesting ways of modifying it was done by Sheila. Thank you very much. Sheila made that in collaboration with Jean-Louis Dubois, in which they said, let's just look at 8 mLs per kilogram to 6 mLs per kilogram and see the dynamic change in the stroke volume and pulse pressure variations. And what they found was, and you can, but you're at 6 mLs per kilogram. You just put in 8 mLs together, you look at the pulse pressure variation. 30 seconds later, you look at the pulse pressure variation, you go back to 6 mLs per, you're done. The test is over. And what they found was that if you have greater than 3.5% increase in pulse pressure variation, your volume responsive, and stroke volume was 2.5. And the advantage of that is it's very sensitive. So You can't see this, but this is Xavier Monet, Belbron and Pinsky. We wrote a few articles in intensive care medicine recently saying, well, all the methods that one has, there are plenty of ways right now that you can assess line responsiveness dynamically in your patient. And the number of devices that are FDA approved that you need are there. You don't need to buy a thing. You've already got the device in your ICU right now that allow you to assess this. The magic numbers are a pulse pressure and stroke volume variation of 10 to 13%, or a change in cardiac output of passive leg raising of 10%, and also the delta pulse pressure of 3.5, which I showed before. Why do you want to know this? It's important because Glenn Hernandez showed that when he was looking at the volume responsiveness of his patients that had septic shock, by 1 hour, patients became non-volume responsive because they just got their fluids. So you're giving them resuscitation. After you give them 1 or 2 liters, they may not need any more, and if you give them more, it's going to hurt them. So you need to dynamically assess this over time. Within 1 hour, they were no longer volume responsive. Okay? Because they've been given the fluids they needed. Okay? So you need to assess it. And furthermore, in our physician data, he said, even if you are volume responsive and you are in shock, if there is a risk of evil occurring from fluids, you may want to under-resuscitate. If you're worried about intracranial hypertension, more ARDS, or intra-abdominal hypertension, you may tolerate a lower cardiac output to prevent the other complications. That's part of the art of being a doctor, not the science. When you use dynamic parameters, it improves outcome. The patients who were admitted to the ICU who require volume resuscitation in this large meta-analysis, goal-directed therapy based by volume responsiveness was associated with decreased mortality, ICU length of stay, and duration of mechanical ventilation. So the physiologic truths, and this is the next to the last slide. These are truths. They might not be important, but I've just shown you what they were before, so I'm going to repeat them now. Tachycardia is never a good thing. You may need it to be alive, but if you're tachycardic, you're in trouble. Okay? Hypotension is always pathological. There is no such thing as therapeutic shock. If the patient's hypotensive, they're underperfusing their tissues, they've lost autoregulation. There is no such thing as a normal cardiac output. One of my favorites, CVP is only elevated in disease. And finally, peripheral edema is of cosmetic concern. If a patient's in shock and they're hypotensive and they're volume responsive, and I say give a liter of Ringer's lactate, and the nurse says, but they got peripheral edema, my response is, this is not a beauty contest. Right? They need the fluid. We may need to give them Lasix or put them on dialysis tomorrow or the next day. I'm not saying that now, but they need the fluid now. So in summary, there's no cardiac output that varies with metabolic demand. Patients presenting from outside the shock often need fluids, but if they're in hospital, maybe not. Preload is not preload responsiveness. You assess the dynamic responsiveness before and after therapy every single time. Just because you're volume responsive doesn't mean you need fluids. CVP does not reflect intravascular status, though it does tell you how good the right ventricle is. Raising CVP is a stopping limit. Fluid responsiveness, assessing only those patients with circulatory shock that need it. With that, I thank you very much for your attention. Come on. That is basic physiology, and everything here you can apply to that subject. And this is me at my boat. I've been sailing for 40 years. My wife took that picture. The hardest thing to do was get the horizon. You know, the boat's tipping, getting the horizon parallel is really tough. It's pretty different. This is that, I had more dark here, now it's in grayer. I don't understand how that happened. Questions? Any questions? Nothing I told you isn't already published.
No, maybe we can make a break right now, there's a long, kind of non-progress process, branch, actually, I'm sorry. And then we can come for very questions.
Certainly. Okay, let's take a break.
Sobre nuestra facility, arriba hay café, agua, los mochitos, y después venimos a
But don't, by the way, before you go, don't you think that the pulse pressure and the mean arterial pressure and the stroke volume going up or down or separately is neat? Because you can use it immediately at the bedside. Okay, it'll always be true. And so as you can dynamically look at response to the patient of what they're doing. It's kind of nice. Okay. Okay.
No.
Yes, yes. I have a question. That's that.
Yes, I, no. So, no tengo, ¿no? ¿Les parece? Vamos a dar unas preguntas, dudas que tengan o cosas que quieran comentar, que mejor pregunta directamente o a poquitos, o si no, si alguien necesita traducción, nos dice y acá tenemos un intérprete especial.
Una pregunta para los no.
Sí,
I have one question. What about the use of vasopressin in septic shock and its impact in the arterial recovery? What do you think about it?
Vasopressin, first of all, I never talked about specific drugs. So this is a new area. Vasopressin is very much a vasopressor without any non-inflammatory. And so, in general, my feeling on vasopressin is it should be given as a supplement to replace the V1 receptor response. So we should give it a 0.02 to 0.04 micrograms per kilogram, no higher. Because if you make it higher, you can squeeze a rock, and all it'll do is make for ischemic necrosis of tissues, like mucosa of the gut or anywhere else. So the use of vasopressin. Oh, and I would not use vasopressin unless I was simultaneously giving steroids and septic shock. Okay, so this you understand. I go up on the norepinephrine, usually to 0.06, which is I start at 0.03, 4, 5, 6. If I see no effect at all, I don't wait till higher. I start with the steroids and vasopressin, and then we'll go up. Because I'm saying I'm not getting the adrenergic response from norepinephrine I should see. Is the problem with the receptor not working? If the receptor not working, vasopressin, if given in a low dose, should make the receptor work again, and then I will see a response. Okay. I have never used angiotensin, though several of my colleagues have. I think it's an interesting drug because it actually protects the kidney. So it's kind of a nice drug, renal protection based suppressors. But I've never used it. I use methylene blue to block nitric oxide at the base of my life. I regretted it. I think when you give a drug that works systemically, because you infuse it in, you are making a philosophical statement. You are saying you know better than the body what you want done. And the body doesn't have the same response that you would have with a drug. If I give norepinephrine or butamine
I'm gonna get a response whether the body needs it or not. And it also will be done across the entire vasculature relative to the degree of adrenergic response. Period. And if a person does not need a vasopressor and you're weaning them off, and I'm sure you've seen this, they actually look better as you take them off the vasopressor, right? If they do, because the vasopressor is taking away your ability to auto-regulate blood flow. So understand, I use a lot of norepinephrine. And I add vasopressin only if they're resistant to it, but only the steroids as well. But I am really against high dose drugs for a long time. If that's the case, we've been considering going on ECMO. It depends on the etiology.
Apart from the septic shock.
Septic shock,
Typical situations that increase adrenaline, you don't get the blood pressure you want, and you see deterioration signs, so injury or anemia. So what do you do?
Well, we actually we did a professor rounds last Friday, last Thursday, in which they presented a case to me of a patient where they went up on the norepinephrine and they went up on the epinephrine and vasopressin, the 8 steroids, and there were very high doses. There was profound lactic acid at 24, and the opened the abdomen and half the bowel was necrotic. Okay? And this had been a previous abdominal surgery in which the bowel was thought to be normal. And it was iatrogenic killing of the bowel. Okay? You can do that. And so I said that I would rather under resuscitate. I'm using massive doses and see if we can tolerate lower levels of blood pressure. Remember that in the ARDS net studies, they had many patients in the treatment groups with PO2s of 50, okay, and 45, and they survived. Okay. So to try to get there with that ARDS, they were not using actively, of course, they were using but they were saying, how can you live with the PO2 of 50? Well, they did. Okay. And if you'd have given them high doses of heat, you would have simply killed them. Okay. So I understand if somebody is dying, you want to do everything you can so that you've given them, so at least in your heart of hearts, you think you've done everything possible to do that. But sometimes what you're doing is you're ensuring that they will die by giving very high doses of vasopressors. And so I tend to be a little bit, I'm very fast to start vasopressors, but I tend to be very slow at going up high. I'll try other things, like, for example, give more blood, make sure the fluid is adequate. What's the name of that? There, it's an inotropic agent. Levosimendan. I've used levosimendan. The problem with levosimendan is it stays forever. Increased mortality. Yes. Well, it increased mortality across the board, but in some patients it might actually help. But the question is, you don't know which patients.
So, actually, you did speak about the specific drugs, and I found your concept controversial, and also based on very small observational studies. For example, you stated that norepinephrine only increased cardiac output in a selected group of patients, and most of the work on norepinephrine showed that norepinephrine has a predictable increase in cardiac output. Moreover, to talk about the increase in stroke volume with dobutamine, some observational studies, including one of our group, showed that dobutamine has very heterogeneous effects, and in most of the patients, there is not evidence of inotropic effects, and stroke volume did not increase.
So, I agree completely that there is a profoundly heterogeneous effect of norepinephrine for you to be absolutely true. But I,
Norepinephrine is not a heterogeneous, or yes, in systemic effects.
no, it is, because with Jean-Louis book, you looked at a large number of people in Paris and showed that it's a significant number. If you gave norepinephrine very early, cardiac output went up, but if you gave it later, cardiac output did not go up. Okay, and we showed with Jean-Francois Deneau in Ontario that if you were to give low dose dopamine and severe septic shock, there was absolutely no inotropic effect at all, either in day 1 or day 3. But by day 6, when they're just to be weaned off the ventilator, they have an excellent response to butyramine. And it's the same patient
In patients who were not septic at that moment,
so they were septic.
1 week after the
No, but-
septic insult.
Well, we know.
This is a key point.
No.
With the experimental background.
No, let me say, this is human beings study, this are human study. The first day was on day 1, then we looked on day 3. On day 3, they were no longer on vasopressors. They were still on antibiotics, but they were thought to be stable. So the argument was we saw no effect with butyramine at 5 mics per kilogram per minute on day 1, but as the reviewer said, they were on rocket fuel on day 1. So you would not expect to see. But on day 3, none were on vasopressors or inotropes, and we saw no effect. On those same patients at day 7 or 6, when they were being discharged, so we would have to take out the pulmonary catheter, we saw an excellent response from all of them. And so what that meant was, to me, and this is what we said in the paper, that one of the things that you will see in sepsis is the downregulation of the adrenergic response, the same way as you see a decrease in insulin response. So one of the things that happens in septic shock is the surface of the cells, glycocalyx, it's altered such that your normal ability of adrenergic molecules to bind or of insulin to bind and cause glucose control is impaired. And so I would fully expect that the response would be heterogeneous. I could not agree more. That's the reason why there is no 1 dose of anything that you give. You have to give the response in titrated response patients. Okay. But we saw in the very first day in more than half of our patients given norepinephrine and septic shock, no increase in cardiac output. Okay, and that's in our paper. And that was, I think, 16 patients. And we only saw an increase in 8. Now, I realize it's a small number, but that's not a consistent response. And it was totally reasonable that there be a heterogeneous response because people, just because they're septic doesn't mean that they were the same beforehand. That's why you have to titrate care to the patient.
It's not obviously.
Some studies where the norepinephrine did not increase stroke volume at the patient or the timing when the norepinephrine was started was late. Or I
No. In Jean-Louis Boul's study, they were over 24 hours. In our study, they were within the first 6 hours. No, so, and we actually addressed that in the discussion. So as soon as the patient came into the emergency room, we took care of the patient in the emergency room. The very first fluid that they got, we gave. So we were managing the echoes immediately. Got their insistol and arterial elastins, and the most they might have gotten was 250 in Nelson fluid. We were the ones managing the patient. Okay? And so, because we really wanted to address the question, in the very very first minutes, if you do the surviving sepsis guidelines, fluids, 30 mL per kilogram, start norepinephrine distance go, and you measure mean systemic pressure, arterial elasticity, pulse pressure, stroke volume variation, you measure it all. Can you predict the response? The answer is you could predict the response, but the responses were heterogeneous across patients. You could tell ahead of time if they were volume responsive or not. And if you gave the fluids, they weren't volume responsive, their cardiac output didn't go up, but you already knew it. The surviving sepsis guidelines said give 30 mL per kilogram. And so, because that was the hospital policy, we were obliged to follow the hospital policy. I knew full well it wouldn't work, but I had no control over that. Now they've changed the policies. The surviving sepsis guidelines have changed.
Michael, let me explain something,
Sure.
because that's something I heard from you many times, that Estados Unidos se supone que lo que muchas, que no, que en Estados Unidos pasa muy habitualmente que están obligados a seguir las guías. Entonces, por ejemplo, si la campaña de sobrevivir a la sepsis dice que los pacientes tienen que sufrir 30 mililitros por kilo, tienen que ser monitoreados de tal manera, o tener una presión no necesitaria, noche 12, lo que fuera, no hacerlo puede significar un montón de problemas legales y económicos para el lugar. Y una de las formas de medir calidad es ver que estén haciendo eso. Por eso, seguramente les está explicando de todos los 30 mililitros por kilo, cosa que no es algo que nos pase habitualmente a nosotros acá, pero es una de las discusiones que hay internacionalmente sobre cuando se escribe algo en una guía. Muchas veces en muchos lugares de Estados Unidos están obligados, it's like what I'm explaining to them is that this policy in the state that you have to follow is strictly what guidance says, and that you can have some problems to do it, don't do that. But going to the practical patient, so you showed the relevance of the diastolic pressure, the main problem septic shock is vasoablation, and that we have to change our mind just to focus on the ventricular tract and when we rest the patients in an individual way, but it's difficult to apply that to that side of the tools you have. So
I
what
want to
you
apologize.
recommend?
What I did was I gave you the basic physiology. It is a totally different lecture to talk about how to resuscitate a patient who's in shock. And this lecture was what is shock, what determines everything. I did not go into the concept of what are the things to do. I was telling you this is how the body works. This is how it works in shock. And note, I have an entire presentation on management of shock, septic shock, etc., cardiogenic shock, and pulmonary embolus. Published work on this, but so I never discussed that. I wasn't trying to tell you how to manage shock specifically. I was telling you why a blood pressure is a blood pressure, okay, and how the heart works, and what is blood flow and blood volume. So but if you don't understand these principles, and if we talk about septic shock or something, you hear Dr. Devon saying he doesn't believe me, you don't understand why he doesn't. You don't understand why he doesn't believe me. Okay, this is the important. I'm talking basic physiology here, and then we can talk about specific management. But until you understand the basic physiology, it's hard to understand management.
You try to talk about basic physiology, but you try to support basic physiology on some evidence which is controversial. For example, I don't have any doubt about the usefulness of responsibility test. But there is no evidence. You showed the meta-analysis which was performed on pediatric patients, not in septic patients.
The one I showed was a septic shock. The study was by Brisnet, was a septic shock patient.
We can see
We can go back.
There are only two very small negative meta-analyses about the usefulness of test of responsiveness in septic patients. Actually, there are only two manuscripts that support the use of this test. One from Cartas, published in Chess, using particular grazing, and another an observational study from the Argentina Society of Terapia,
Was not.
in which we showed that the use of dynamic tests after the fluid loading of 30 liters per liter reduced mortality. But there is no meta-analysis of what.
The meta-analysis was done on the second shot, but the study by Douglas was a multi-center prospective randomized trial.
Yes.
And it wasn't just one center. And they showed significant improvement in outcomes. And so I personally do not like doing large prospective clinical trials, and I've got many papers in which I've said that it's impossible to properly do a prospective clinical trial on a syndrome. Because syndrome is not a disease. Sepsis is caused by many things. People have different degrees of cardiovascular, immunologic reserve, and resiliency, and they respond differently. So there's not going to be a specific best treatment that works on all patients. And I know you agree with that.
It is, of course.
And so that's why we try to focus in on what pathophysiologic processes do we want a treatment to address. But in my next lecture, if I assume I do it, my lecture will be on effective hemodynamic monitoring. That is what outcomes based on real measurements, increased mortality, increased length of stay, increased incidence of renal failure in human beings that apply. But it wasn't the monitor, it was the treatment based on that. And one of them will be not to give fluids in a non-volume responsive patient. That's a good thing. It's good not to give fluids in a non-volume responsive patient. It's good. You should behave that way.
In addition, from an ethical point of view, probably randomized control trial testing the usefulness of liver consequences. It's not feasible.
Yes, everybody believes it. But in the original days, it didn't. And so that's why we did look at it. And so we knew it would be accurate, but nobody else did. And so we did it in this hospital where they didn't believe in it. So we said, fine, this is what you're doing anyway. We're going to measure it.
Question for both of you, because probably we go.
Did you hear her?
Probably we go to, we have this next lecture, but there is a question I really have, and I want to know your opinion, is that all the evidence we take from to decide on clinical practice comes from randomized clinical trials, where we put the group really different patients from some sepsis. So we said septic shock, the definition of septic shock or sepsis, and we have focus on urine infection and peritonitis, pneumonia, and we put everything there. And then we do measurements, and so most of those studies and in results that show no difference between groups. So there is no evidence for anything. Actually, what's going on is happening with the shock guidelines. It's that the level of evidence, the guidelines are coming in 2024. The level of evidence is very low because most of the randomized control trials show no difference.
Well, the reason they show no difference is because they're
but
beneficial and detrimental to the state groups.
yeah, so probably is that in the C group, there are some patients that receive the benefits, while others have a detrimental effect, and so in the average
What is your question?
group, there is no difference. What do you think should be the next studies we have to do. So where's the direction to go in clinical trials? And what do you think is coming with the monitoring of the human health situation invasion for the next decade?
Well, that's an interesting question. And the first thing I would do is I would take off the table things that we know work. The one thing we know for sure in septic shock is that rapid blood culture is followed by broad spectrum antibiotics. And that's narrowing the antibiotics is necessary. It's very good. And the faster you do it, the better you are. And that makes sense from a lot of levels because septic shock is an infection. So I do not want to do a study randomizing patients to get antibiotics or not antibiotics. Okay? Okay, so that I can take off the table. We know from the Chris Seymour's paper in the New England Journal on all the children in New York State that every hour of delay within the first 6 hours of being identified as sepsis had a 5% or 10% increase in mortality. Okay, so but only for antibiotics. If you look at the same analysis for giving fluids, don't that do it? And so there are certain things we know for sure, and one is that septic shock is due to infection. Okay. So I feel very comfortable with taking off the table. We're going to normalize the antibiotics. Now, which antibiotics you want to use because you think you have a better idea of what antibiotics we can look at. But I think antibiotics no longer should be considered something you want to study, yes or no. They may be what antibiotic or what's portion. I don't disagree. So where I think we're going is we need to create subgroup analyses prospectively. The problems we've had is that everyone wants to show that if you give this drug or you do this management, everyone's sepsis is better. When in fact, there are multiple types. In children, they say that there are 5 distinct phenotypes of sepsis. Children have a much more definable. One of them is the macrophage activations. That specific group do amazingly well with steroids. I'm just saying. And Joe Carcello, one of the world's experts, who's at the University of Pittsburgh in pediatrics, has been studying the macrophage activation syndrome and has to do with some heavy metal or cadmium or something that's present in the blood that they can acid. But be that as it may. So they have been able to take a subgroup, say in the children that behave this way, they're able to study this versus that. So the real question is, we know, for example, we did all our trials, that urosepsis, intra-abdominal sepsis are having totally different mortality. So we probably should not be adding urosepsis to intra-abdominal sepsis in clinical trials. We can do studies of urosepsis, yes, but they should be separate. So I'm a big believer, and then we also know that gram positives are much worse than gram negatives.
Are more what? Sorry.
Gram negatives do not have the highest high mortality as gram positive septicemia. We got very excited in the 1970s and 80s about gram negative infections because of the immunocompromised hosts. And of course, the staph and strep are still pretty bad. They are very bad antibiotics, very bad bugs. So I think that we can still study infection in subgroups for other specific things, but we should not study should they get antibiotics, yes or no. Okay. Now, with regards to the other things, we just published a paper that there are 4 groups of patients that had COVID-defined ARDS that had totally different trajectories, cytokine levels, etc. And when we looked at the 2 groups at high mortality, 2 groups at low mortality, one of the factors that did not determine which group you were in was age. So age, and as we're talking at 450 patients prospectively studied at Columbia University in New York. Okay, we did a machine learning analysis of all this stuff. And this became important because age was not a factor. Now, granted, if you were immunocompromised, that was a factor, but age was. So, well, being older, I'm kind of glad that wasn't a factor, but I expected it to be a factor. And even when we looked at the groups together and said, let's just put age in anyway.
God, didn't find it.
It didn't separate you into groups in terms of mortality. And age alone was not a predictor of mortality. So anyway, our problem, we are, Alan Morris and several other people, and we have a paper we're writing now saying we should no longer be using the results of prior clinical trials in critical care medicine of syndromes. Because syndromes are not patients. An acute myocardial infarction due to ST segment elevation on the left anterior descending is the same in everyone, relatively speaking. And the treatment of that can be very unified. And I know exactly when the myocardial infarction started, the ischemia, their chest pain, etc. So in coronary artery disease, one can have a very homogeneous population, which is the reason why in cardiology they made such advances in the management of these various and also percutaneous aortic valve replacement, etc. They've been able to do because it's very homogeneous, single organ system problem. We deal with acute kidney injury, ARDS, or sepsis. The causes of these are multiple, and I don't expect one treatment to fix everyone with ARDS, everyone with sepsis, or everyone with AKI. And so I think we need to go back and seriously consider the different subgroups. What we're proposing in this position paper is that using artificial intelligence and what's called a nearest neighbor. If we have I personally have a 90,000 patient database that I have. The waveform data, electronic health record over 12 years of ICU patients delivered because they're linked to their outcomes, possible stays, everything. And so with that large database, I can then look at you if you come in and say how many people were your age with you comorbidities and not very sick, but I get this treatment and you responded this way. Who else responded this way? Same group. And then predict from that what your pathway will be going forward or whether I need to change your treatment. And that I can do in real time. So that's important. In this way, I'm only using data of patients that behave exactly like you did at one step. And if everyone did exactly like you did at one step, chances are they're going to behave the same way the next step. This is the strength of that sort of an analysis. And when you start to deviate from it, which you can, you're changing into another group. And we can say, now we're seeing more of this or the other. So one of the things that we're proposing, and this will be done more once I'm retired, because it's going to take a couple of years. But we have the databases where we'll be having an American database of ICU patients. The National Science Foundation, the NIH, have given us the money to create a 19 hospital system. Ours has 90,000 patients. UC San Francisco, University of Chicago, Mass General Hospital, Emory, I can't remember the others. There are 19 hospitals. They're all big ones. And so that will give us, at least from an academic center, statement of what do patients do in general. And if you know all the drugs are, and so if you have a large enough population, then you want heterogeneity. You want different treatments for the same disease across patients. You want that because then it allows you to dissect that things work in that patient. So it may never be that we'll be able to say to you, this is how you should always treat you. But I can tell you right now, this is how you treat it. Okay.
Let's move back to basic physiology.
Okay, I like this.
You suggested that endotoxin challenge induces an homogenization in the pressure flow relationship among different vascular beds.
It does, when I give endotoxin, there is an immediate release of histamine in animals, pigs and dogs. This causes histamine's a vasoconstrictor. It causes an immediate increase in hepatic blood flow resistance. So, immediately. So what you do to do the studies properly is you give little doses of endotoxin to get the mast cells to degranulate so that you no longer have that. And this is what we write in papers. And then once that's done, then you start to give an infusion of endotoxin until they get to a certain level of hypotension. That becomes very uniform and you can look at it. The other thing that we did early on is we infused endotoxin into the left atrium so that it went to the whole body first and avoided the lungs, okay, because of the pulmonary hypertension we also saw. So it's a model, but the problem with any endotoxin model is it really doesn't represent true sepsis, right? But it's an overwhelming inflammatory model. So when I showed you with animals where they homogenized, that was at a very high level of inflammation. I don't know what would happen with, for example, cecal ligation and perforation 36 hours or 2 days later. I don't know. We never measured that.
I'm thinking the clinical message. In an experimental model of endotoxic shock with vasodilation, we found that the renal circulation
Increases.
no decreases. Yes, yes. Despite the normalization of systemic hemodynamics, renal blood flow, regional blood flow, and microcirculation remain deeply effective. On the other hand, mesenteric blood flow, superior mesenteric artery blood flow, and the line microcirculation were preserved. And there is a clinical correlation in patients to maintain renal function. It is necessary to get a chair blood pressure higher than 75 millimeters mercury. So I don't believe that there is an homogenization.
What I said, I still have to look. But what I said was is that the marked differences between the organs, which were really quite marked, is lost when you
Not so much.
yeah. Well, the kidney is very different. What if you were to measure, let's say you go into the operating room with an animal, you feel the kidney, and let's assume that this is my kidney. So I can squeeze it a bit. It'd be firm, but I can squeeze it. Okay. See what I mean? You induce shock and you're resuscitating, you squeeze it, part is around. What has happened is the kidney has swollen inside its capsule, and the capsule is holding it. For watch, kidney has a pelvis and it's like that, but the capsule is only on the outside. So I get a selective hypertension and constriction of the cortical blood vessels because of this increased pressure. In 1932, a nephrologist, I think it was a urologist, a urologist, I thought it was in Germany, opened up the abdomen of a person with acute renal failure and removed the capsule, and the kidney function immediately returned.
This is one who did average.
So there's a lot, the determinant of the lower blood flow in the kidney is not just due to something else. It's very complex.
Okay, in our model, the kidney was decapsulated.
You did encapsulation.
No.
Yes, in order to get the cortical microcirculation by video microscopy.
they're not hospitalization.
Yes, we encapsulate, measure.
Ya, solo para explicar, estamos hablando de el shock endotóxico, que se vio.
But that is not,
And the decapsulation theoretically protects the kidney.
yes, it does, theoretically.
It was not our findings.
We've only encapsulated 1 and 2 kidneys. It's the only, because we only want to study the microcirculation of monosteroids. We don't have 2 cameras.
Okay, and in Charla, I'm pretty sure was the same in both kidneys.
Really?
Capsulated and decapsulated.
Well, I actually measured intravenous pressure with a Molar catheter in one of our studies, and the pressure was very high. I think up to 20 millimeters of mercury. And when you felt the kidney, it was hard as a rock. And my assumption was it was the capsule. Because the encapsulation, taking off the surface.
After how many hours of experiment? 8 hours.
Yeah, we do long experiments.
4 experiments were 2 hours and a half.
Oh. I don't even start it. It really depends on what the question is trying to answer. But there is no complete homogenization of blood flow, but there is for sure, and I didn't show they were all the same, I showed they were similar. And based on that, we also did studies in animals in which we gave norepinephrine to raise blood pressure and showed that unlike under normal conditions in a dog, we measure superior mesenteric artery and renal artery flow and give norepinephrine to raise mean arterial pressure by 20 millimeters of mercury. Their flows go down. The endotoxin, their flows went up. Okay, we published that in the Blue Journal years ago. And so it was that data that the surviving sepsis guidelines gave initially to say, these are the data that defend the use of vasopressors in septic shock, because otherwise, all vasopressors have to squeeze on vessels. And if they squeeze on vessels, they must decrease blood flow. Right? I mean, isn't that true? I mean, I thought it was. And if it's true, then how can it possibly be good? The answer is because it's not, the vessels that you squeeze that are in the kidney and the gut are not responding as well. So what you're doing is you're getting other organ systems like the skin and the muscle redistributing blood flow. Okay. Yeah.
How about the physiological?
Oh, I love physiological questions, especially based on the lecture.
You show that when arterial pressure rises or arterial elastance rises, stroke volumes go down.
If nothing else happens.
If nothing else happens.
Yeah. And that I can show this in the cardiac cath lab. I can show this anywhere around.
Talking about the 2 other mechanisms that happens in a human being.
Yes.
Stalling mechanism and the unwrap mechanism.
Yes.
If the patient modifies when you go when your arterial pressure rises and the end-diastolic volume goes up, the starting mechanism allows the patient to sustain the stroke volume, and then the unwrap mechanism in an intact heart, not a diseased heart, sustain the stroke volume. So you will lose I go up with the pressure, down with the stroke volume. And now patients within that cardiac failure. I actually, my question about expressing is related to that.
All right, so I read on the words.
No.
That doesn't, it looks like it's too light. Yeah, that is no black.
No, that was,
There's good.
we can tell it. No.
Good. So. Is this the reason? So, if you rapidly increase arterial pressure, the increase in incidence, the left ventricular pressure volume is very steep. The slope is much steeper than that slope. When the left ventricle contracts, you make the pressure higher. The determinant of afterload is wall tension. And if we were to look at a circle, the radius of curvature, tension is equal to the radius of curvature squared times pressure. What happens between in diastole and insistently is the radius of curvature increases by fourfold. So it goes from 4 inches, 4 centimeters to 1 centimeter, something like that. So this gets cut very small and the arterial pressure rises. And so under normal conditions, the left ventricle unloads itself during ejection. Louis Katz got the Nobel Prize for that observation many years ago, 1955. So under normal conditions, we do not have significant changes in systolic pressure. More cost of work if you keep the pressures constant. In heart failure, though, the curve flatter. And there, as the heart is ejecting, radius of curvature doesn't change that much, doesn't well out here. And so in heart failure, the tension doesn't go down from the increase in radius of curvature because the heart's dilated. And so you're much more responsive to systolic pressure. And that's why patients in heart failure do extremely well with afterload reduction. That's why normal people do extremely poorly with afterload reduction, right? And that's because you are designed to tolerate a high systolic pressure. You all understand that? So because you unload your left ventricle with ejection, you can double your mean arterial pressure. Now it might give you a headache, but it won't hurt the left ventricle. Now, what he was talking about is what about preload the afterload? Starling's law of heart is designed primarily to match the output of the right ventricle and the left ventricle. Because with every breath, there is a marked increase and decrease in venous return to the right ventricle. And the amount of change in right ventricular volumes in inspiration is really amazing. If you measure biventricular pressure volume, the left ventricle is staying like this, the right ventricle like this, all over. Because the venous return can double in inspiration and expiration. So the goal of the Starling's mechanism is a way to match the output of the two ventricles, not beat to beat, but over a couple of beats, so that they're always about the same. The NRAP effect is primarily responsive if you have increased arterial pressure. So the way NRAP originally described the NRAP effect in its original work that was published actually in the 1920s, but it described and it's now used routinely in the models of cardiologists, is that you increase the load on the left ventricle and you follow the patient over the next, follow the animal over the next 15 minutes, and you see it increase, the stroke volume progressively increases as you increase the contractility. Okay? So that's the normal ANRAP effect. What I'm talking about is an instantaneous change. You give fluids, you give a pressure, and you look within 5 minutes, and then you're gonna see an up or down. After time, they'll all have to go up, down, or go up relative to the metabolic demands of the body. Because at the end of the day, what counts is the body, not what you done with the heart. Remember, the goal is the circulation is for the body, not for the heart. We simply measure the response to our treatment based on these dynamic changes, okay? If I give a vasodilator, I expect the stroke volume to go up and the blood pressure to go down. Okay? A vasoconstrictor, I expect the blood pressure to go up and the stroke volume to decrease. If I've got a good heart, the stroke volume might not increase very much, but the blood pressure will go up. If I have a bad heart, the blood pressure will decrease a whole lot. Okay? You with me? Good. And so that's, but the unravel thing, it lasts maybe at most 3 to 4 hours. Maybe.
You come you know, like in experiments, and yes, I'm not experimenting.
Yeah.
You come here, and you have a preserved starting mechanism.
Yes.
Stroke volume. It's maintained, despite the increase and pressure. And then there's a point when
You can't.
the standing mechanism doesn't work anymore, and that's the point when stroke starts to.
Well, there is really
Go
no,
down.
there's no descending level of the Starling curve. What it is, you just totally destroyed the heart. You know, the tissue is tissue, right? It's not metal, it's not a piston part. And so, and the actin and myosin have to come together. And so even though we call the like elastic set, it's truly curves, because at some point, tissues can't do anything. They start to rupture, okay? But over the operational range, what we deal with is very tight. And one of the things I disagree with Jean-Louis Vincent. He wants to show the Starling the installing elastic like this. If you look at any of the studies that are done recently with really good conductive scaffolders, the left ventricular installing elasticity is very steep. Very steep indeed. And though there are small changes in systolic pressure, they're very small. There are major changes in diastolic pressure. But so in other words, the reason, I never told you this. We talked about systolic elastics. Let me show you this. Let us assume that I were to ask you at one point in time, I'll do a whole bunch of different things. Okay? And I say, all right, at 20 seconds after the start of systole, where am I on this curve? Let's say right here, right here, right here. Okay, at 40 seconds, right here, right here, right here. At 60 seconds, I'm right here. What you've got is progressively increasing stiffness of the heart. And it's a time varying stiffness, time varying elasticity. What contractility is basically this. How much stroke volume you have is a function of your preload and its ejection pressure. But every single heartbeat is this. Now the problem with that is that if you have an installing elastic like that, here's your left ventricular pressure. This is stroke work. But this area here is potential energy that you're wasting. And that whole area is called the pressure volume area, potential energy that. And the pressure volume area is directly proportional to the MV over to myocardial oxygen consumption. Anything that increases the pressure volume area increases oxygen consumption. If you have a high pressure here, you have this massive pressure volume area with wasted work. So a person in heart failure cannot tolerate hypertension. They will go into heart failure, worse heart failure very quickly. Whereas you have a very small potential because you're so steep, so you can tolerate hypertension. So it's perfectly reasonable for a young person coming into the emergency room with a broken leg that was systolic arterial pressure of 180. They're in pain. They're not heart failure. If you give an old person like me 180, I might go into pulmonary edema. Probably not, but you never know. Okay. So I don't want to try it. So the point is that the anoramic effect and the starling mechanism are both meant as short-term effects. They are how the body controls itself from one heartbeat to the next, but the starling mechanism, and over very short periods of time, the anoramic mechanism to increase contractility. They are designed for survival for acute things. To run away from the saber-toothed tiger as you're being chased, or to catch the bunny if you are the saber-toothed tiger. In either case, it is to survive a very short effect. You aren't supposed to be running a marathon. The very first person who ran a marathon arrived in Athens, fell over dead. Okay, remember? Remember? Okay. No one expects patient in the ICU. The body does not expect the patient in the ICU to be that sick for 2 days. You're expected to die. Your body is expecting you to die. And so the adaptive mechanisms we have don't work. That's why I said the anoramic and the starling, the acute stuff, the hypertrophy, dilation, the chronic, we live in the middle. That's where we fight. Fight between those two things to get the patient alive. Shall I do the final lecture? Ready?
Yes.
Okay. This is a presentation that I modified and gave in Santiago, Chile, to Glenn Hernandez's course as a plenary lecture. I want to say a month ago. And what this is answering the question, what hemodynamic monitoring has been good for patient outcomes? Okay, what I wanted to tell you is that there are many books that have been translated into Spanish recently. This book that Pinsky, Tabul, and Vincent edited is available in Spanish. And my applied physiology book and functional hemodynamic monitoring have been translated into Spanish. So to the extent that you feel more comfortable reading a textbook in Spanish, these books are available in Spanish. All right. So just so you know, if you're interested, I don't get any royalties for these books. They're available. I personally like the applied physiology because it's a large compendium of many papers over years. The hemodynamic monitoring just came out a couple of years ago. It was extremely well selling. Okay. So let's not lose track of why we're doing what we're doing. Hemodynamic monitoring is part of an ongoing assessment of the physiologic state and the functional status of the patient. Okay. The essence of it is that no two patients are the same. Okay. You do not treat everyone the same. You never should. You should look at your patient and treat them. Okay. And it needs to be contextualized. Are you monitoring them in the perioperative emergency room, operating room, ICU, or on the floor? Hemodynamic monitoring will be different wherever you are. And are we talking about an acute management of a patient or someone who's coming in to see you once a week for chronic dialysis care? What are the disease we're trying to treat and comorbidities? So there is not going to be one special answer. So one of the ways to look at it is the concept I said before, and that is that no monitoring device can improve outcome for patients, period. It's the treatment that does it. So what
treatments need specific information to allow them to work. Treatments that are known to work. You don't take a catheter and say, let's see how many people I can treat with this catheter. You say, what are the treatments I know work? What information do I need to guide therapy in an individualized way to this person? Okay, that's what monitoring should be for. All right. Different environments demand different rules. If a person goes into the emergency room, first of all, I think they're in a hospital. They're not. Emergency rooms are not hospitals. Okay? The goal is to minimally invasive. They don't want to miss a thing. So they'll draw 5,000 tests on a patient rapidly. Okay. They want to make sure they don't miss anything. They might overdiagnose stuff, but they don't want to miss anything. Okay. It's mainly for triage, trends, and protocols. This is where we track. This is where sepsis is treated acutely from the outpatient. In the operating room, it's literally the exact opposite. And you want to be very accurate. You want to be invasive if necessary, and you want to have extreme specificity. Zero tolerance for error. Okay, zero tolerance for error. So those are the two extremes. The ICU is somewhere between the two of us. All right. So we like to triage. We like to do protocols. We want to get interesting stuff. We would prefer not to have any errors, but we have a larger palette that we have to work with. Non-ICU floors are not defined at all in terms of what you want to do. There's absolutely no recommendations in terms of what you do on the floor. But in general, the rule is that if you're going to monitor, you want an untethered, non-invasive monitoring. A pulse oximeter you can walk with, an ECG electrodes that's on a monitor, or that you come by once in a shift and the nurse measures these things on you, okay? There's going to be a lot of false positives and false negatives. The blood pressure, the automatic blood pressure cuff says it's terrible and it's really good, so they repeat it the second time it's fine. Okay, so they're the problems. So we can look, and this is the concept that DJ Piana and I developed years ago, that we have levels of intensity of monitoring for emergency room, ICU, the operating room, pre-op. It can be minimally invasive, or highly special, like echocardiography. And if you were to look at the structure, that the different environments, different intensity, different invasiveness, you actually see that there's a culture of monitoring that is different across different systems. Okay. So if any of you go into the operating room, you'll notice that they don't monitor the same way or look at things the same way as they do in the ICU, because they have different philosophies of what they're doing. And they're also doing it within the context of acute surgical trauma. So the mantra for monitoring is always want to be continuous, non-invasive, and metabolic. Just keep saying that over and over again. To the extent that it can be continuous, you have the greater degree of sensitivity and specificity because you can see trends beautifully. If I measured your blood pressure once a year, which is what a private practitioner would do for your health evaluation, that's usually pretty good. Okay, if you're in the ICU and I measure you once a year, it's probably not good at all. So it really depends on the context. In the ICU, to the extent you can measure things continually, the better you are. Non-invasive, the level of invasiveness increases the level of complication. The reason we add invasiveness is to improve the accuracy of what we're measuring. If I don't need invasive for accuracy, I don't need invasive. Okay? We give invasive monitoring to improve accuracy. And metabolic. At the end of the day, the only thing I care about is tissue wellness. I just can't measure it. So I have to measure surrogates of it. But if I can measure metabolic things such as pulse oximetry, capillary refill time, cleft variability, these are metabolic parameters. So these are the things that I would like to do. So the future of monitoring, this is not a lecture on the future, is to find ways that we can use this sort of approach to guide therapies that we know work. Because they can be used in a trend way to figure out if somebody's getting better or worse. So this is the paper that came out in critical care. 2022. Michael Pinsky, Mauricio Salmi, Michelle Chu, Daniel Backer, Ivor Douglas, Mark Edwards, Olga Azlani, Glenn Hernandez, Greg Martin, Xavier Monet, Vernon Siegel, John Sharon, John Louis. These are all very smart, dedicated people. We came together, I divided them together, and I said, I don't care what you monitor, what improves patient-centered outcome across the various things you're looking at. I think that's the joke, all right? What improves patient-centered outcomes? And this paper, by the way, is highly cited. And so we separated it into the following things. So let me give you an example. You can have extremely specific technique, but if given to the wrong population, it worsens their outcome. An example is ECG monitoring. ECG monitoring is continuous ECG, is extremely useful in patients at high risk for acute coronary syndrome or who already have acute coronary syndrome to monitor them. If you did ECG monitoring people without coronary disease, you increase their complications. They actually have worse outcome. SpO2 was phenomenally useful for triage of COVID. Probably the best use of pulse oximetry is to have a patient who comes in hypoxemic and put them on oxygen and see if their PO2 improves. Because if they come in with a PO2 of 85, we put them on low flow oxygen, their PO2 goes up to 95, then you know they don't have shunt, they've got VQ mismatch, they're probably a COPD or they're very, very early on. But if their PO2 doesn't budge, you admit them to the hospital. Okay, so that's an example of triage in a very selective population that improves the effective management to get them into where you work. I do not know for COVID if it ever changed outcome, but I know for a fact that there are numerous papers that have shown that selective ECG continuous monitoring patients at risk for acute coronary has improved outcome. Okay. There are other things which are less well understood, and that's guiding for preemptive resuscitation. This is called pre-optimization. The example is high-risk surgical patients, mainly abdominal surgery. You take them before they have their surgery, and you increase their cardiac output to some minimal amount to prevent hypotension during the induction of anesthesia and during the time that they're having the surgery. This was classified as the optimized study. And the pre-optimized 2 came out and it found no difference. It hasn't been published yet. I reviewed it for a journal, and the journal didn't accept it. And I can't go into many details, but when they asked Mark Edwards, who was the author, in an interview on YouTube, which I saw, he said that 50% of the patients in both groups, unlike before, were getting minimally invasive surgery. In the original optimized, almost no one was getting minimally invasive surgery. So it may be that they're not dealing with the same types of populations of patients between the two. Monitoring response to therapy. This is what Arnaldo was talking about. Using functional hemostatic monitoring for shock triage and optimization phases. Remember that in shock we have the initial rescue, and then we go for salvage phase, and then we do the optimization, and after that it's stabilization and de-optimization. So there's no data to show that monitoring in the stabilization and decreasing, weaning them off things that it works. So I do believe that it does enrich from hypotension with dialysis. And finally, we have the ability with artificial intelligence by looking at the hemodynamic waveforms to say this patient is going to become hypotensive. This patient is going to have a septic episode in the next 2 hours. And if I tell you somebody's going to have a septic episode in the next 2 hours and they're sitting right in front of you, you will assess them to say, where are the infections? You'll probably get blood cultures going and you'll make sure you have a good line in them and try to figure out what's wrong. And if they start to get sick, you'll immediately start antibiotics. I wouldn't start antibiotics until the receptor unless you really believe the monitors, and nobody monitors that good. But that would be a way of going. So I'm not going to describe these, but this is table 1, which lists all the things. I'm not going to go through the data for these. It lists all the things which have been shown to improve outcomes. In the pre-optimization, it has reduced complications, ventilator time, and hospital and ICU length of stay for patients. Functional hemodynamic monitoring has been increased the amount of volume infused and the time that patients are hypotensive of a functional level, which is the time that the lactate is elevated divided by the time, which is called lact time. It's monitored. Also, hypotension prediction. This is the hypotension prediction index by Edwards, and in open honesty, I was the one that recommended them that they create the group to cause a hypotension prediction, but they didn't follow my mechanism of how to do it, but they did create the group. Then in the emergency department, we know that surviving sepsis guidelines, if done in a programmatic way, like giving early antibiotics and cultures, decreases mortality. We don't know if giving fluids has any effect. Okay. Functional monitoring in the emergency department, as we saw from Douglas's paper, clearly decreased the amount of fluids that the patients got and improved less hypertension time. In the ICU, functional hemodynamic monitoring increases the amount of fluids given, which, by the way, in our very first paper, we said that functional hemodynamic monitoring will identify those patients you shouldn't give fluids to. That was the first thing we said. And then it'll tell you if they need fluids that they should get it. Okay. Decrease hypotension time and ICU management. We know now we measure the norepinephrine, the pulse pressure variation, the stroke volume variation ratio, which is dynamic arterial elastance. If you're on norepinephrine and you're being weaned off norepinephrine because your blood pressure is normal, if your dynamic arterial elastance is greater than 1, you won't become hypotensive if you step down the usual step. If it's less than 1, you will. So with that as a simple rule, several groups have now shown, Enon was the first, that you can markedly decrease the time that patients are on norepinephrine infusion when being weaned off it without a risk of hypotension. Okay. So I'm not going to go through these individually because they're just too much. But this is a study. Let me say something. This is a study looking at the timing of goal-directed therapy of a pre-optimization type. This is given within the initial surgery or the first 6 hours in the hospital. This is after 12 to 24 hours in the hospital. Meta-analysis that was done in 2014. As you can see, there was a benefit given early. There was no benefit given late. And this simply states that timing is everything. The exact right treatment will be totally useless if given at the wrong time. I know this sounds obvious, but it needs to be said. Okay. So there is, like I say, I tried to use it, it didn't work. When they were there 2 days, I tried it, somebody said we should try it, it didn't work. Well, it should have been given within 6 hours of them coming in because you were trying to prevent the process, not treat it once it was there. Okay. As you can see, process was part of that group. Process was the multi-center study of pre-optimization that was organized and run by the University of Pittsburgh, Department of Critical Care Medicine, Derek Angus and David Lamb. And then the clinical trials of meta-analysis looking at complications after surgery also showed the same thing. This is the study by Pierce et al., which was optimized one. And it showed that it was really interesting. When they did the original study, I told them that I didn't want them to increase cardiac output and look at all patients right away. I wanted them to take the first 2 or 3 patients in any hospital that was part of the group that we randomized, collect the data, but not use it. Because it takes 2 or 3 patients to get the system working so that you can accurately say that you did the optimization. They're from England and they're poor. They couldn't afford to throw away the first 3 patients. So they left the first 3 patients in every group in. And they found just missed accuracy. When they did, for me, because I was one of the reviewers of this paper, a post hoc analysis that they could not publish, just eliminating the first 3 patients in all groups, was a significant benefit. But they can't publish that. I was very frustrated. So the editor said, this was Derek Angus, who's the editor, it's my chair. He said, I want you as part of your paper to do a meta-analysis of all the papers. This is the meta-analysis of all the pre-optimization studies, and it found a statistically significant benefit. Okay. As you can see. So based on that, there was a feeling that pre-optimization improves outcome. How does it do it? If it does it at all, it probably does it by preventing micro hypoperfusion during high-risk surgery of various people, whether it be the gut or the kidney. And the most common thing it prevents is post-operative infection. And post-operative infection is ischemia. Okay, just so you understand. So there's a lot of consistency here. So one of the other things that we decided to do was to ask the question, how invasive do we really need to be? So in this position paper from the European Society of Intensive Care Medicine, and Jean-Louis Goldberg, sound familiar? Daniel Rebecca, Christoph Hofer, Xavier Monet, Ezra Farrell, Michael Pinsky, Daniel Ruben, Andy Rhodes, Pierce Horrod, Jean-Louis Vincent, and Tom Schmidt. So it's kind of the same people over and over again. We've been doing this for a lot of years and trying to study it. And what we looked at was less invasive cardiac monitoring, because less invasive is probably better. And the principles that we came up with were these. You want to ramp up your monitoring. If you need the least monitoring and you get the effect you want, don't do more. Okay? You only do what you need. And do it in a sequential fashion. Intermittent, non-invasive is traditional vital signs, echo, and X-ray. Continuous pulse ox, arterial waveform, cardiac output base, those can be done non-invasively. And then you can invasively put in a central line, try to stop the icon. And you can have a continuous invasive. This is an arterial line. Central venous line, PA catheter, transcutaneous. So this is the progressive amount of what we have. So the causes of cardiovascular insufficiency can be really obscure and are often multifactorial. So even if a person has hypovolemia due to blood loss or vomiting, increased spacing over time, that's increased unstressed volume. Remember we said that? They're not all treated the same way. Vasoplegia occurs with a lot of things: spinal shock, anesthesia, anaphylaxis, and sepsis, and impaired left ventricular stroke, volume, kidney contractility, but can also be RV failure, pulmonary embolus. And you can have 1, 2, or 3 of these things in your patient. Your patient doesn't come in with a single diagnosis as the cause all the time. Sometimes they have a mixture of these things happening, or these things happen further over time. But no matter what, the options we usually have in the treatment fall into three. Independent, of course, you give antibiotics, but in terms of the cardiovascular side, the hemodynamics, it's volume, pressors, and inotropes. Okay. So non-invasive vital sign monitoring is the most common thing used in all hospitals, including in the ICUs. It includes the heart rate for the ECG, and the impedance of the ECG signal gives you respiratory rate. So you see both heart rate and respiratory rate. We have pulse oximeter density that also gives you an estimate of stroke volume. The ECG, as I said, gives you the heart rate, you can get temperature, and then you have blood pressure. Now, what I wanted to talk about for a second is why you should not use a non-invasive automatic blood pressure monitoring test critically ill, unstable patient. Okay, I'm sure you've all seen these things like Dynamath. They come on, you press a button, goes up, and then all of a sudden you see a number, right? You're familiar with this, right? Everyone uses it. Okay, they don't work. They are not recommended for hemodynamically unstable patients. Okay. Why am I worried about blood pressure? Well, the body defends blood pressure until the end by vasoconstriction. So hypotension is always pathological, and the beat-to-beat variations are going to show you changes in stroke volume rather than cardiac outputs. They're not useful. So we can use pulse pressure variation to assess line responsiveness. And as I showed before, hypotension is associated with kidney injury and mortality, and it's the length of time. So the most common method that we use today to measure blood pressure is a automatic blood pressure cuff. And it uses a pneumatic, usually in the forearm, on the arm, but it can use the forearm, you put it on the thigh, and it has poor accuracy. This is how they look. Put on, press the button, it blows up to a certain level until it hits a common pressure, and it goes down. What it looks at is as the pressure rises, it looks for the point in time in which the pulse pressure doesn't change. When the pulse pressure changes, then it pulse that one systole and that one diastole. That's how it works. If you were to look at the exact same data on inflation in red and deflation in blue, you would get a different pressure. So they take the two and average them. If you look at the accuracy of these to determine blood pressure, they have an accuracy of about 60%. But probably more important, let's look at this Bland-Altman analysis. This is the difference between a manual measurement with a sphygmomanometer, you're measuring the Korsakoff sounds with your own stethoscope, and the blood pressure cuff. This is differences of 0 to 30 or minus 30. Look at two standard deviations. If you think the pressure is, the mean arterial pressure is 60, it might be 40. Or you think it's 40 and it's actually 60. Do you think that'll change your vasopressor use? And the same is true on the other side, the hypotensive ones. If you really need to know blood pressure accurately, either measured by hand using a sphygmomanometer and a stethoscope, or put in an arterial catheter. This is the recommendation of all the medical societies. Okay? Non-invasive are great for non-specific things. They are not great at all for acutely ill patients. Okay. So what would the approach be? Well, the approach is initially for acute circulatory failure, put in a central catheter, essentially a catheter, for a stable site for infusion of fluids and maybe drugs. Clinical measurement, a lactate echo and cardiac arterial catheter if the patient's in shock. Okay, lactate, because if your lactate is not elevated, then you're probably not in shock. But measuring lactate a bunch of times I've never found to be useful, at least acute. So the clinical assessment is profound, and it's the one that everyone forgets to do. And it needs to be done continuously and repetitively. You come back and look. Level of consciousness, capillary refill time, modeling of the skin. Do they have ileus? Looking at evidence of hypoperfusion can be seen at the bedside and can be quantified. Echo should be done immediately because it's amazing how much it can stratify patients into disease processes. Echo is not a continuous hemodynamic monitoring device, and it's subject to interpretation, but it's amazingly useful. There are intermittent measurements of several cardiac functions from echo. And the central venous catheter allows you to measure central venous pressure, SpO2, and the arterial venous CO2 gradient. I like the arterial venous CO2 gradient, not so much for spark exchange force, but I like that. What? I know you know that. I know you don't. And the reason I like it is because if the arterial venous CO2 level is high, this suggests hypoperfusion of the periphery. Not that the periphery is in shock, but it means that for the normal metabolism, the flow back is so slow that the level on the venous side is higher than it should be. So a value above 6 suggests that the flow through the gut is slow. Through the tissues is slow. Central venous pressure is a very important value. I've never said never use it. What I said is CVP doesn't tell me volume status or volume responsiveness. Okay. But central venous pressure is profoundly important in assessing right ventricular function. And no matter what, it is always the back pressure to venous return. So if your CVP is 12, your pressure in the periphery has to be 24 or you don't have any blood flow. And that means you're going to have edema, intra-abdominal hypertension, and other things happening too. You got to figure out why the right heart's not working. And I know that Arnaldo doesn't like the PaCO2 to PCO2 ratio, but I like the PCO2 gap because it tends to be more specific for hypoperfusion, not for shock, but that there's a decreased blood flow. You can have a hypoperfusion with all organs still functioning well. And if you're exercising, you should see an increased PCO2 gradient, but that's normal response to exercise. So one has to understand individualizing that for the patient. So what we said in our effective hemodynamic monitoring was that some forms of distributive shock, I can have a normal SCVO2 because areas that have high flow don't need the oxygen. And areas with low flow will suck it out, but when they come back on the venous side, it's going to come out, it's going to add up to a high CO2. So I can have a high mixed venous CO2 and still have areas of the body which are underperfused. That's the reason why I like to measure the AVCO2 gradient, because if I've got evidence of shock, and the AVCO2 gradient is higher, then those would be patients with whom I would do a trial of increasing cardiac output to see if organ system function improves. Arterial catheter. As you know, the arterial catheter pressure is more than one value. The diastolic pressure, I believe you now all accept. If your diastolic pressure is less than 40, you've got vasodilation. Okay. If your heart rate, the diastolic pressure ratio is greater than 2, you're vasoplegia. So it's useful for that. You saw the shock index. I'm not going to show it to you again. But in terms of the functional hemodynamic monitoring, you saw that stroke volume variation is the pulse pressure variation. And we know that the stroke volume is proportional to pulse pressure. And in a large meta-analysis, Paul Merrick et al. Showed that measures of pulse pressure and stroke volume variation, but they group both together,
were extremely accurate in predicting volume responsiveness. And more specifically on this side, if you did not have stroke lung or pulse pressure variation, you weren't volume responsive. So as a way to tell me, don't give fluids to this person, it's very useful. Now, there are a lot of problems with the use of pulse pressure and stroke volume variation. You have to have a type of volume at least 7 or 8 mLs per kilogram. You can't have spontaneous breathing. You have to be on a ventilator. So a lot of patients that aren't on it, but if you are, it's good. These are the, if you're on a low tidal volume and you still have a pulse pressure variation, you're volume responsive. But if you're on a low tidal volume, you don't have a pulse pressure variation, you don't know. That's why you do the tidal volume challenge. Okay. But if it's present on a low tidal volume, you're volume responsive. Okay. So it's just, but if it's not there, you don't know. You can't change. That's the basis of Sheila Meister's recommendation for looking at the pulse pressure and stroke volume. And that has now subsequently been analyzed by multiple groups. And Jean-Louis Thibault gives a lecture on it, which he shows the meta-analysis of all these studies. But I'm not here to critique those down. Once again, it's 3.5 and 2.5. And as I showed you, our paper in critical care, this is a legacy. We talk about the various acid light rates and any fluid challenge, pulse pressure variation, stroke volume variation, the next part of that's the tidal volume challenge, which I really like, assignment of. So there are multiple ways of looking at the exact same data and determining the volume responsiveness. And as I said before, all these things are there, and as you can see, the tidal volume challenge threshold is there, and you're on a ventilator. Pulse pressure variation greater than 13%, stroke volume greater than 10. And as I said before, let's be honest, I thought there'd be a different group for the US election than the other. You have to continuously reassess this during the resuscitation, because this is the amount of patients who are responders to gray. This amount of non-responders. So at the beginning, 2/3 of the patients were responders. Good. But after an hour, almost nobody's a responder. And by 2 hours, it's rare that you're a responder. So if you continue to resuscitate a person without assessing volume responsiveness, you're going to be giving excessive volume to a lot of people. So you have to continuously reassess it. And as I said before, even if you are volume responsive, if the risk of fluid accumulation is high, you have to titer it. Remember, you're a doctor. You're here to help the patient. I don't care if they're a little bit hypotensive, if you prevent them from getting acute kidney injury, pulmonary edema, or intra-abdominal hypertension problems, it's probably a good thing. Now, this was the study of parameters in post-surgical patients. This one was post-surgical. And they showed that, in fact, if you use goal-directed therapies in post-surgical patients, it improved outcomes. The outcomes that they had in this was post-op time in the hospital and complications being infections. This is the study in the septic patients I showed you before. This is septic shock patients by the group. And in their group, they found the same thing. And as I already read to you what they found. Furthermore, you can look at specific organs. And this is looking at all the post-op complications. This is a new meta-analysis of multiple studies. And it's still showing consistently positive responses. In most patients, at this point in time, your monitoring's done. They're resuscitated. But in some patients, they're still not stable with just this amount of monitoring, and you have to go on from that. And that's where you have to look at their profiles, for which you need to have continuous monitoring of either cardiac output or transcutaneous. So basic monitoring is usually enough. So I would say in a given 10 patients, maybe 1 or 2 we need advanced monitoring. Okay? But you got to be quick. So transpulmonary thermocoagulation or pulmonary artery catheter are used to assess continuously cardiac output, intrathoracic lung water, and ventricular function and pulmonary hypertension if you're worried about the right ventricle. So
In the consensus conference that a bunch of us wrote years ago, we suggested to use these things in patients where there is ARDS because you want to minimize lung water. There's no data for it. This was low evidence. So what we said is in ARDS, it seems reasonable to manage such complex patients. It seems unreasonable to manage such complex patients without PHF or some measure of lung water. Because otherwise, echo is not suited for continuous monitoring. So the pulmonary thermal dilution allows you to also measure lung water. But unfortunately, looking at the increased lung water permeability is associated with increased mortality, but no one has shown that titrating care to that has reduced mortality. So regrettably, I personally can't recommend it. Not that I don't think it shows something, I just can't use it. So in summary, echo should be done soon, but echo is now monitored twice. CVP and arterial catheters are essential. Ramp up monitoring as needed. Add additional devices only in high volume people. Monitoring response to therapy is probably more important than the absolute values. With that, I'll stop. I have to use the bathroom, so I'll be back. Okay.
Vamos a llevar a tomar algo y poder ayudar a no poder parar, terraza, luego salir del día para él.
I drank so much water, I was really in trouble.
Okay, thank you very much. Thank you very much. You have questions?
Question. I have a question. The intra-abdominal pressure doesn't have. Intra-abdominal pressure doesn't have any role here.
No, we were talking, remember I showed you the risk? Yes. One of the things was intra-abdominal hypertension. And in the very first lecture, I talked about organ perfusion pressure in the kidney and the gut is mean arterial pressure minus intra-abdominal pressure. So intra-abdominal pressure is very important for those reasons. Couple of things. One, we tend to measure intra-abdominal pressure as a static measurement at end expiration using a Foley catheter. But if you were to measure it continuously during positive pressure breathing, it would go up and down and it would be much higher than what we see. And though I'm a big believer in making intra-abdominal pressure at a consistent spot to be accuracy as it changes over time, the fear is that if you are on positive pressure breathing, and you only use an expiratory value, you're underestimating the true negative. You're underestimating the true intra-abdominal insult. I personally think that high intra-abdominal pressure contributes a lot to a lot of the complications we see in minimally invasive surgery patients who come back to us and then end up having some degree of kidney injury or gut dysfunction, because though they're not supposed to go above 12 to 15 millimeters of mercury in intra-abdominal pressure during these procedures, I assure you they go up to higher values if they need to see, like for gallbladders, they have to get below the gallbladder, and they blow up more to get into that area. And so,
we are probably gonna see more problems with increased intra-abdominal pressure over time. Also, intra-abdominal pressure, by its ability to increase the ability of the diaphragm to ascend, makes lung compliance appear to be decreased, when in fact it's chest wall compliance that's decreased. And so one of the other problems is it compromises mechanical ventilation, and it misdiagnoses lung disease as being lung when it's actually diaphragm. So that I think intra-abdominal pressure is profoundly important.
Because of the presence of young physician, I need to say something about the Vinotia VCO2 that you love so much. Not only you, but also these cohorts. Vinotia VCO2 is frequently recommended for the monitoring of tissue perfusion or
Arterial CO2 or
veno-arterial CO2.
venous to arterial?
Venous minus
I
arterial
did not
CO2.
hear the venous to arterial.
Venous minus arterial CO2. Actually, veno-arterial CO2 is a surrogate only for cardiac output. And even for this
Which
purpose,
one? The venous or the arterial?
venous minus arterial CO2, the gradient between venous and arterial CO2 depends on cardiac output.
Of course. And
But
metabolic.
also, it depends on CO2 production, and a very important factor that you have overlooked, that is the dissociation of CO2 from hemoglobin. And even in the absence of changes in cardiac output, there can be very large changes in the veno-arterial CO2 gradients. I insist, even in the absence of cardiac output. For example, cardiac effect, hemodilution, metabolic acidosis, acute changes in ventilation. For example,
Okay, so let's stop for a second.
a decrease of only 3 milliequivalent per liter in base excess increased veno-arterial VCO2 by 50%. So, veno-arterial VCO2 is misleading.
The Haldane effect. The change of acid base rarely occurs continuously and rapidly over time.
I completely.
There's an initial effect that occurs in shock, but once that's happening, it stays relatively constant. I agree with you that if you're having acidosis, the buffering of bicarb will make CO2 to be present. There's no argument. There are three causes of CO2 that would be seen in the venous blood. One is, of course, metabolism of carbohydrates to CO2 and water in the electron transport chain, but also with the Krebs cycle. In the Meyer-House cycle itself. No argument. Second one is buffering of acid by bicarb. But if you're buffering by bicarb, the level of acidosis usually remains constant. In my experience over years, if a person's acidotic and they're being resuscitated, their pH tends to stay very constant once they start with the resuscitation. So the dynamic changes aren't there. I agree with you that it's not as accurate as many people would like, but the beauty of the AV-CO2 gradient, and I like it, and we teach it to our fellows, is that if the patient is not doing well, and you've been measuring central venous O2, if central venous O2 sets well, they have a low cardiac output, or they're increasing their oxygen consumption relative to their cardiac output. If it's normal and they still aren't making urine and you're wondering what's happening, and you say, is this a person who would benefit from a higher blood flow? That's when we measure the arterial venous CO2, because the question is, if it's high, you say, okay, let's do a trial of fluids or inotropes or whatever to increase cardiac output, and then look to see if blood flow gets better.
For example, for this purpose, we have published a paper showing that the increases in cardiac output induced by dobutamine were not together with decreases in venous minus arterial PCO2 because of the simultaneous increase in mixed venous oxygen saturation and had an effect hyperoxia. Hyperoxia increases in arterial PCO2 while cardiac output and microcirculation remained unchanged. For this reason, I state that arterial PCO2 is misleading. It depends on several factors and control factors.
You all know what the hell they have. Yeah, no, no. The red cell carries oxygen, but it also, when it's deoxygenated, carries carbon dioxide on the hemoglobin. But if you put oxygen on it, it unloads carbon dioxide. And that's what it's supposed to do in the alveoli. It's part of its job, is so that it can bring back some CO2. And then if the oxygen comes on it in the alveoli, because that's what the alveoli is supposed to do, it allows more CO2 to come off. It's a pretty good deal. Okay. But the point is, if I've got profound low venous blood, O2, and I now make it better with increases in cardiac output, then I'm going to see an artifactual increase in CO2. And I don't disagree. But what I said to you and to the group was, if my initial mixed venous CO2 is low, and I mean, is normal, sorry, not low, is normal, and I'm still concerned that I might be hypoperfusing the curve. Of course, I said, in those patients, I draw it because that's the group I'm specifically interested in. I do not draw it generically in everyone. But if the arterial mixed venous CO2 oxygenation is normal, I can still have abnormal oxygen delivery to the tissues because of blood flow distribution support. The good thing about carbon dioxide is 100 times more diffusible than is oxygen, and therefore I will see areas of maldistribution manifest as high CO2 fluxes, where I won't see it from the oxygen shunt as well. I mean, it's not perfect. You cross clamp the mesenteric artery, you're gonna lose the gut no matter what. You won't see it anywhere. But it's very good for generalized heterogeneous flow. And so in the patients who have a normal SVO2 with 70, 75, 72 to 5, and you still wonder if they're low, measuring the arterial venous CO2 that's high suggests that they are hypoperfusing.
What happened in this patient with normal central venous oxygen saturation and high venous minus arterial PCO2 has a normal high pressure, a normal urine output, a normal capillary refill time.
No, I would never look. No, but what I said to you was, if they're not
Please
well,
answer my question.
then I wouldn't worry about it. I wouldn't care.
Okay.
What I said was that if you have a patient who is not responding, it's in low urine output, altered mental status, etc. That's what I said. And you have a normal SpO2, and the question is, will increasing cardiac output be better? Measuring the arterial venous CO2 that's high, you say, okay, I will do a trial of increasing cardiac output. And that's exactly what I said. And I stand by it.
If the patient is hypotensive, is oliguric, and with a poor peripheral perfusion, you also will try to increase cardiac output.
And you'll also try to increase blood pressure. I'm talking about the patient that you think you've resuscitated and they're doing well. That's what I would do. And I actually, we measure microcirculation, and the one thing I find that doesn't work is looking at the microcirculation. Capillary refill line works if you're not on vasopressors. But the point that is always going to be that most patients who you resuscitate, just giving them fluids if they're line responsive, a little bit of vasopressor if they're vasoplegic, and getting antibiotics if they're septic, and then addressing the primary problem if they have a massive pulmonary embolus or myocardial infarction, they get angioplasty, whatever it is. In almost, let's say, 80% of them, that's going to fix it. It's in the other 20% that are complex, mostly because they have multiple etiologies of the disease. They're not just a single disease. Okay? And that's not surprising because our patients come in with comorbidities of chronic obstructive lung disease, diabetes, hypertension, peripheral vascular atherosclerotic disease. Okay? So these people may not respond the same way as an otherwise healthy person with the same treatments. And they're also at a higher risk of complications. So in that population, if you've reached your targets of blood pressure and flow, and they still don't look like they're doing well, but you can, of course, go up on the mean arterial pressure. Remember I said start at 65, but go up as needed to maintain perfusion. It's not a problem at all to go up to 75 or 80 if you can without having to give massive doses of varipamil to do that. And if that's all they need, then you say the patient likes mean arterial pressure of 80. Okay, that's okay. But once you've done that and they're still not making urine, and you're still you're saying they're still, I don't know if they're under resuscitated. I don't know if I need to be more aggressive. I know being more aggressive carries a lot of risk. Then you have to assess the functionality. And that's where I use the arterial mixed venous gas. It's high, I say, this person looks like they could have a higher cardiac output, and I would give dobutamine to that person. And I've done that.
The glutamine might increase cardiac output, but not decrease the arterial PCO2 because of her same effect.
Oh, I don't care. Well, wait a second. I don't care if it alters the arterial mixed venous. I want to see if it made organ function better. If the dobutamine, all of a sudden they start bleeding, I smile and say, good, let's leave them on it for the next 6 hours and see if they continue to improve. And at which point we'll taper them off it. I don't need to measure the arterial mixed venous again to say it's working. I mean, you might want to if you don't, but what I'm looking at is this a reason to increase cardiac output, knowing that anything that increases cardiac output will have a risk associated with it as well. I'm trying at all times to do the least amount, but as fast as possible to stabilize the patient. That's always the goal. Okay, the least amount to stabilize the patient quickly. I feel very comfortable with that statement. Any other questions? Sir.
So what do you do when you have a patient who has high levels of PVC before the shock status? Do you perform CVP? Sorry, a patient who has a high level of CVP and then he becomes with shock. Do you perform a fluid responsive test?
Yes, you can. But the point is, the patient that comes in with existing high level of CVP is going to be at a very high risk of complications, because even though it means that they have right-sided failure and potentially hypertension, maybe right ventricular hypertrophy, I don't know. The reality is their cardiovascular reserve is markedly reduced. Okay? And so they're going to be at high mortality. So what we would do initially in a person like that is look aggressively if we can identify something to decrease right ventricular afterload and improve right ventricular performance. And the best way to improve right ventricular performance, independent of increasing pulmonary artery pressure, is to increase arterial pressure to maintain coronary perfusion. Because the right ventricle mainly perfuses in systole because it's such a low pressure system. So the treatment of right heart failure is norepinephrine to raise mean arterial pressure, not fluids. So the first thing you do is focus on the right ventricle. I give an entire lecture on right ventricular pathophysiology. There's some beautiful work documenting that the best thing to do is to immediately start norepinephrine to restore coronary perfusion pressure. PA pressures will even go up a bit further, but cardiac output will go up too because the right ventricle is now functioning better. Okay, and I routinely, I'm a pulmonary doctor, and so whenever I see a patient ever coming in high right ventricular pressures, CVPs, and not responsive initially to resuscitation, my #1 diagnosis is always pulmonary embolus or hyperinflation.
I start with, they say, am I dealing with a person who's got asthma or something, he's just ridiculously hyperinflated? Or is this a pulmonary embolus? Because those are two things I can treat immediately. I sleep at night saying just pulmonary embolus, pulmonary artery. It's one that it never leaves my mind. Never leaves my mind. Okay? Because the right ventricle cannot handle high pressure. Yes, sir.
It seems reasonable from a physiological point of view that we can use the CVP as a safety limit. But the observational data from all the studies that gave fluids and measured CVP fluids and post-perfusional fluids show that the response of the CVP is the same in fluid responders that in fluid non-responders. And
that was
that's difficult to understand if you look
I've had a hard
if you look
time.
at it in a physiological point of view.
Yeah, I've had a hard time with that because I've seen the studies. And they show that but if you look at the numbers, they're talking about CVPs of 12 to 14.
Yes.
That's grossly too much CVP. So that's the problem. Your CVP is 0, and if it's over 8, you're sick. Okay, and if you're a Charla Magistral, you would say that anything above 8, there's no increase in volume. You're on the flat part of your right ventricular Starling curve. Okay, so and I think he's probably right, but I'm not. I'm not sanguine about 12 versus 8, but be that as it may. If your CVPs are that high, and that's how they are in those studies, I think that's too high to begin with. And I wouldn't even have been there in the first place.
Michael, and couple to his questions. What do you think about this oxymoron of the concept of fluid responsiveness and fluid intolerance at the same
I
time?
just showed that. I agree. I just showed the slide. It showed fluid intolerance, but fluid responsive. And I said, you may be fluid responsive, but you are intolerant to it in terms of having intra-abdominal hypertension, intracranial hypertension, or ARDS. Okay. So in those cases, I say, and I said to you, I thought I said to you, that I would limit that fluid, and even though they are fluid responsive, I would say that, it's first do no harm. I can tolerate hypoperfusion, a little bit of hypoperfusion, better than I can severe volume overload or intra-abdominal hypertension. Intra-abdominal hypertension or ARDS can be very, very hard to treat.
That would be used, for example, central venous pressure in a patient with ARDS who is ventilated with high levels of PEEP and has signs of tissue hypoxia, and then you can find the patient has a fluid responsiveness but a high CVP, so it's difficult for me.
First of all, I agree. What I said in this is that those are the patients who you put a PA catheter in or transpulmonary because you need more information. Okay? And you could then identify, is this a person with pulmonary hypertension? Or is this a person who just has ARDS? Okay? Without pulmonary hypertension, for example. I would treat pulmonary hypertension differently than ARDS. So the point is that in that patient, which is very complex, you need more information and you need to follow it. And that's where we recommended the PA catheter, the transpulmonary thermoevolution catheter that gives you the lung water and permeability index, etc. And then based on that, there are ways of thinking about the physiology for sure. And so in those cases, then you have that information. Now in my world, I see a lot of pulmonary hypertension because of the nature of the patients that we treat for pulmonary transplant and for other diseases. And so, and I'm part of the pulmonary hypertension clinic, so we see a lot of them get admitted to the hospital. And so I give a lot of iloprost and various pulmonary vasodilators patients and we see an amazing improvement. If it's an isolated pulmonary vascular resistance problem, I can get them out of shock almost immediately with a pulmonary vasodilator. Okay? Assuming they're vasoresponsive to the vasodilator. If it's just ARDS with no pulmonary problems, then they rarely have elevated CVPs and pulmonary pressures unless I'm already going overload. The last thing I wanted to say, and this is important, and Antoine Boulard-Morin and I, with maybe Xavier Monet as a co-author, are going to be showing a large quantity of data that shows that if you resuscitate a patient until they are zero volume responsive, with pulse pressure variation of less than 5, I mean, really flat, they are in core pulmonality. If you push a person that far, they have paradoxical septal shift, they may have tricuspid reverge, their right ventricular diameter is larger than their left ventricular diameter. All the criteria one uses for core pulmonality. Their E to A is almost non-existent during diastole because of that too. And so, so what I would do in those patients is I would first do an echo, but then if I did identify the problem with that, they would then go to advanced monitoring, as I said. And I didn't go into that because that's an entire lecture on its own. Not that I'm against it, but so if it turns out they're pulmonary hypertensive, I treat them like pulmonary hypertension, maintain coronary perfusion pressure, try to find a vasodilator selectively for the lungs. You pick the one you like. We like iloprost in Pittsburgh. We like inhaled nitric oxide, but you can take whatever one you want. They're all quite good. If they don't have problems with gas exchange, they're relatively safe. If they do have problems with gas exchange, we go to ECMO, the BD ECMO, and that almost always drops PA pressures, except for maybe 15% patients. And that's how we treat them. But like I said, with the exception of what happened with COVID, which was pretty impressive, we're not seeing as much of that now. I'm sure we'll have another COVID equivalent pandemic. The question is not, will we have another one? The question is, when will we have our next one? But we will have another pandemic. I hope it won't be for a couple of years more, but you never know. We got too much international travel and too many people eating food around, eating live animals in Asian countries where there's, and some in Africa where there's too easy zoonosis, transfer viruses back and forth. This kind of happen. Gotta get used to it.
Thank you for coming.
Sí, sí,
Yes, the occlusion technique.
yes, yes.